Happy Naida? Need to try with the partner?
Good afternoon, ma'am. Dr. Supriya, ma'am. चारू दिख नहीं रही है। हाँ, तैयारी है पूरी। कमिला दी है लग रहा ना।
हाँ, नहीं मम्मी भी अभी ज्वाइन करवा के आती हूँ उनको।
अच्छा अच्छा।
राकेश जी, हेलो, अनीता एंटरप्राइजेस से कौन है? अंजना जी प्रणाम। ये टेक्निकल सपोर्ट से बात करना जरूरी है।
जी मैम, बोला जाए।
हाँ, वो एक्चुअली देखना चाह रहे थे शुरू से कि थोड़ा सा फ्लो दिखा देते आप, एक लाइटिंग द लैम्प का,
जी
और वो दिखा देते। और उसके बाद जब वेलकम एड्रेस अंजना दी वो कर लेंगी ना विनीता दी, तो
जी
1 मिनट के लिए हम बोलेंगे उनका फॉक्सी प्रेसिडेंट का मैसेज डिस्प्ले करने के लिए।
जी
ठीक है, तब आप कराइएगा, जरा दिखाइए तो।
जी
और उसके बाद जब वेलकम एड्रेस अंजना दी वो कर लेंगी, 1 मिनट के लिए हम बोलेंगे उनका। मंजू दी म्यूट कर लीजिए। आप कराइएगा। शेयर करके देखिए। हाँ हाँ, जाओ।
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते। दीपज्योतिर्नमोऽस्तुते। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः। शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः।
ठीक है। और वो द मैसेज बाय फॉक्सी प्रेसिडेंट डॉक्टर शांता कुमारी। अंजना दी वो कल डाली थी लोग ग्रुप में, तो उसको हम कहे कि सब लोग बोली हैं कि हर प्रोग्राम कराता है ना लोग, तो थोड़ा सा उसको शो करे उनका मैसेज, तो वही
आफ्टर एवरी टॉक।
नहीं, शुरू में ये जैसे दोनों प्रेसिडेंट लोग अपना वेलकम बोल लेंगी ना,
हाँ।
रेखा दी और विनीता दी दोनों का हो जाएगा, उसके बाद हम उनको एक बस बोलेंगे कि so शांता कुमारी हैज सेंट अ मैसेज फॉर ब्रेस्ट फीडिंग, ये वाला
तो यहाँ पे एक लाइन जोड़ देते हैं ना।
हाँ
ऑलवेज अंधेरा स्टॉप
नहीं तो उसमें आप हमको बोलिएगा, हम बोल देंगे, या तो ये लोग दोनों जैसे वेलकम खत्म करेंगी हम बोल देंगे, हमको बुलाने का जरूरत नहीं, हम अपने बोल देंगे, उसके बाद आप साइंटिफिक पिकअप कर लीजिए।
breastfeeding, shared responsibility. Foxy stands for all mothers and newborns. Foxy celebrating the World Breastfeeding Week, and we urge all members to participate in this initiative. Data says that India is lowest among the South Asian countries. Only 44% of our mothers initiate breastfeeding within 1 hour of delivery. And it's our responsibility to see that
कितने
we
देर का है
number of women who breastfeed.
राकेश जी कितने टाइम का है ये? 2 मिनट का।
WHO has identified that poor infant feeding practices
तो सुनाना ही
contribute to the neonatal death, and this is something which we have to look into.
50 सेकंड का है मैम।
Friends, when you see the data,
2 मिनट 50 सेकंड का है।
ठीक है, अभी बंद कर दीजिए, उस वक्त जब बोलेंगे तो प्ले करिएगा।
जी
ठीक है, 2 प्रेसिडेंट है ना, जैसे कि डॉक्टर विनीता सिंह बोल लेंगी, फिर डॉक्टर रेखा झा बोल लेंगी, उसके बाद हम इनको सिर्फ बोलेंगे कि देयर इज अ मैसेज फॉर ये करके, और बोलेंगे आपको प्ले करने तो आप प्ले कर दीजिएगा।
ढक दिए ना।
हेलो दी, वसुंधरा दी।
हाय सुप्रिया, कैसी हो?
ठीक है,
उनको हमेशा देखते रहते हैं। चलो बहुत अच्छा सुप्रिया,
थैंक यू। आपका हम इंट्रोड्यूस आपको प्रतिभा दी करेंगी, और हम आपका टॉक के बाद वाइंड अप करेंगे।
क्यों?
मतलब ऐसा आपको इंट्रोड्यूस करेंगी प्रतिभा सिंह, वो आपकी चेयरपर्सन है।
हाँ चलो ठीक है।
बहुत अच्छा, चलिए सब लोग टाइम से तो जुड़ गया, लेकिन जानती हैं आज व्यूअरशिप उतना लोग रह पाएगा कि नहीं जानते, हम तो बहुत सब जगह डाल दिए हैं ये प्रोग्राम का, बहुत प्रोग्राम हो रहा दी एक ही साथ।
बहुत ज्यादा हो रहा है, वेबिनार होने से हमको लगता है एक दिन में कितना प्रोग्राम हो रहा है।
ये भी तो बहुत लेंदी प्रोग्राम है ना, 4 टॉक है, बहुत देर चलेगा, ये 8 बजेगा।
नहीं दी, 15 मिनट बोले हैं, अब देखिए 5 मिनट
तो देखो बहुत सारा चीज है ना, इट इज आप बियॉन्ड आवर कंट्रोल, वी कांट डू एनीथिंग।
तो
बहुत सारा चीज हम लोग के कंट्रोल के बियॉन्ड हो जाता है।
हाँ, बीच में रोक भी तो नहीं सकते हैं बोलने में।
ना, अब रोकना क्या, अब जो हो गया सो हो गया।
विनीता दी ने जुड़ी बात कर। अंजना दी, क्या हुआ है ना कि फैकल्टी, हाँ विनीता दी आप ज्वाइन नहीं किए? बोल रहे थे ना अंजना दी, क्या हुआ कि शुरू में चूंकि पता नहीं चल पाया था फैकल्टी लिंक और इसका डिफरेंस, तो एक्चुअली सर्कुलेट हो चुका है सब जगह। तो हम लोग सिर्फ ये रिक्वेस्ट करेंगे शुरू में कि भाई ऑल द पीपल हूएवर हैव जॉइंड प्लीज कीप योरसेल्फ म्यूट। म्यूट करने के लिए बीच में बोलना पड़ेगा, क्या सब लोग जुड़ेंगे, सब लोग इसमें अपना वीडियो ऑन करेंगे या बोलने लगेंगे तो बड़ा मुश्किल है। राकेश जी आपके पास वो है कि म्यूट ऑल का ये ऑप्शन
होगा ही,
है ना?
जी
जरूर होगा।
वीडियो का तो नहीं होगा, सिर्फ ऑडियो का होगा।
जी जी
जैसे ऐसे होता था ना, तो कभी क्या है कि एक ही लिंक दे दिए दोनों को
जी
और फैकल्टी को अपग्रेड कर लेता है लोग, तो जैसे जितने लोग इन्वॉल्व हैं जो आपको ईमेल्स दिए थे
जी
उतने लोग अपना वीडियो ऑन करके दिख सकते हैं, उस टाइप का भी ऑप्शन रहता है और जगह।
जी जी
तो आगे के लिए इसको भी ध्यान रखिएगा।
जी ठीक है।
गुड इवनिंग सुप्रिया, गुड इवनिंग अंजना दी।
गुड इवनिंग दी।
Where are you?
Hello, Anjana Di.
I'm not able to see you.
You
She is
can see me
there.
now. I think you can see me now.
Yes.
Yes. So how are you?
Good evening, Supriya Di.
गुड
Good
इवनिंग।
evening, Rekha ma'am.
Good evening. ये बताओ सुप्रिया, मुझे क्या करना है? I did not ask you.
मैडम जैसे शुरू में लाइटिंग वाला फिर सब अंजना दी अपना सब करके वो आपको कॉल करेंगी, विनीता दी वेलकम एड्रेस देंगी, और ये आपको भी प्रेसिडेंट भागलपुर सोसाइटी टू से अ फ्यू वर्ड्स टू एड्रेस द गैदरिंग करके बोलेंगी। तो आपको जो बोलना होगा इंट्रोडक्टरी बोल दीजिएगा शुरू में ही।
ये व्यूअर्स लिस्ट किसी में है क्या डॉक्टर?
हिसाब बनाया था, लाडू चाट हिसाब दे दो।
भी आती है इसमें। गुड इवनिंग निभा। गुड इवनिंग निभा, चारू।
Good evening, ma'am.
तो प्रणाम हो गया है। एंड गुड इवनिंग विनीता।
Good evening.
Good evening,
Nikita
good
Di.
evening, good evening, Charu. Looking so pretty. Sangeeta?
प्रणाम रेखा मैडम।
Good evening, Dr. Basundhara.
गुड इवनिंग।
डॉक्टर किरण सिंह ज्वाइन की हुई है ना?
प्रणाम किरण मैडम।
कैसे ज्वाइन करती?
Good
गुड
evening.
इवनिंग विनीता दी।
Good
हम
evening,
लोग
madam.
का मिक्सअप हो चुका है एक्चुअली लिंक।
हाँ,
तो-
लिंक मिक्सअप हो गया है।
हाँ, तो खाली हम लोग को ये देखना है कि जो लोग मतलब बोलते रहेंगे वो अपना अनम्यूट करेंगे, बाकी सब लोग को ध्यान रखना पड़ेगा, म्यूट रहना होगा। ये एक तो हो गया है।
अच्छा, कोई बात नहीं।
कोई बात नहीं, अच्छा है, सबको हम लोग बिल लेंगे आज।
वो जो वर्चुअल बैकग्राउंड तुमने भेजा, उसको वर्चुअल बैकग्राउंड कैसे बनाना, वो मेरे को अभी फिगर आउट करने का कोशिश कर रहे थे, तो नहीं हो रहा था।
ये लोग दिए हैं वर्चुअल बैकग्राउंड, अगर आप चाहें तो लोग।
आई वाज ट्राइंग, लेकिन हो नहीं पा रहा था। मतलब डेस्कटॉप पे पड़ा हुआ है, बट आई कुडंट मेक इट। आई थिंक जूम में जाके पहले से स्टोर करना पड़ेगा।
जूम में चेंज करना होगा, वो हम भी नहीं किए हैं।
मैम वर्चुअल बैकग्राउंड के लिए जूम को पहले खोल के फिर स्टार्ट वीडियो लिखा है मैम, वहां पे ऊपर एरो दिया हुआ है, उस एरो पे क्लिक करेंगे मैम।
हाँ,
तो उसमें चूज वर्चुअल बैकग्राउंड का ऑप्शन आएगा मैम।
वो तो देखे हैं, लेकिन अभी
हाँ।
कर सकते हैं वो?
जी मैम, कर सकते हैं आप।
नहीं, अभी मतलब जैसे इफ आई डोंट वांट टू लीव दिस मीटिंग एंड देन स्टिल डू दैट, तो होगा क्या? आई डोंट थिंक।
मैं आपको गाइड करता जाता हूँ मैम।
ट्राई करते हैं। हाँ, बोलो। वो तो दिखा रहा है, लेकिन आई डोंट थिंक हो पाएगा।
तो वही स्टॉप वीडियो, जहाँ स्टार्ट वीडियो लिखा होता है उसके ऊपर एक एरो।
गया ये उस दिन नहीं आ रहा था। उस दिन नहीं आ रहा था।
स्टार्ट वीडियो के ऊपर मतलब वो करने के लिए ना, आई हैव टू लीव द प्रेजेंट मीटिंग। दैट इज व्हाट आई एम नॉट ट्राइंग टू से। अच्छा, प्रॉब्लम आता है।
नहीं मतलब जैसे
तो
हम
इस
बोल रहे हैं,
बैकग्राउंड को कैसे लाएं राकेश जी? जैसे मान लीजिए
छोड़ देते हैं
स्टॉप वीडियो करके भी चेंज वर्चुअल बैकग्राउंड, तो
जी
वो कहाँ पे आएगा बैकग्राउंड?
हाँ, उस दिन इसलिए
जहाँ पे मैम स्टार्ट वीडियो या स्टॉप वीडियो लिखा हुआ है,
हाँ
उसके ठीक बगल में देखिएगा मैम, एरो मार्क जैसा बना है आप ऊपर की तरफ।
हाँ
जी, उस पे क्लिक करेंगे मैम, तो एक पॉपअप मेन्यू खुलेगा और उसमें होगा चूज वर्चुअल बैकग्राउंड।
हाँ, वो खोले, उसको दबाए।
जी। उसके बाद मैम यहाँ पे ऑलरेडी वर्चुअल बैकग्राउंड कुछ दिया हुआ होगा आपके पहले से। उसको आपको जहाँ वर्चुअल, उसमें एक प्लस का साइन भी होगा मैम, वर्चुअल बैकग्राउंड लिखा हुआ है, और सबसे राइट हैंड साइड में एक प्लस का साइन है, उस प्लस के साइन को दबाइएगा तो आएगा ऐड इमेज।
आया।
ऐड इमेज को दबाने के बाद मैम ये वर्चुअल बैकग्राउंड वाला फोटो जहां रखे हैं उस जगह पे आपको जाना है। वर्चुअल बैकग्राउंड कहाँ डेस्कटॉप पे सेव होगा तो डेस्कटॉप पे जाके उस फाइल को सिलेक्ट कर लेना है मैम।
एक्चुअली अगर पहले से डाउनलोड किया हुआ है
तो हम तो
नहीं
नहीं
तो
किए
नहीं
हैं।
होगा।
अच्छा, डाउनलोड करना होगा पहले में।
हाँ, तो अगर नहीं डाउनलोड किया तो उसको लीव करके तब ना डाउनलोड होगा।
नहीं नहीं नहीं, मेरे पास डाउनलोडेड है स्टिल।
देन आप उसको ऐड कर लीजिए।
इज द ओनली वे। नहीं नहीं, बिना लीव के मीटिंग नहीं होने वाला। हम लीव नहीं करना चाहते हैं बिकॉज बड़ा कनेक्शन का प्रॉब्लम रहता है, कभी कनेक्ट होगा नहीं होगा।
मिस्टर राकेश,
जी यस मैम।
I want to test my presentation.
Okay, sure ma'am. Yeah, I have made you co-host. You can proceed, ma'am.
Slide share screen.
Yeah. The screen, you have to share the screen, ma'am. Yes, ma'am. Yes, ma'am.
ठीक है, thank you.
Okay, welcome, ma'am.
प्रणाम प्रमिला दी।
प्रणाम।
प्रणाम मैडम।
सब लोग खुश रहिए।
प्रणाम मैडम।
प्रणाम प्रणाम।
निभा दी, गुड इवनिंग।
इवनिंग। मेरा हम खुद ही को किसी को देख नहीं पा रहे हैं, कुछ तो हो गया वो ऐड करने के चक्कर में। देखते हैं उसका बैकग्राउंड कहाँ दिया, इतना मेहनत से दिया तो शायद हो जाए साइड बाय साइड। तो किसी का हुआ है क्या?
पहले से करके रखने से होगा, बाद लास्ट मोमेंट में बड़ा दिक्कत होता है।
वही दिक्कत है।
इसलिए हम नहीं ट्राई ही नहीं किए, पता चलेगा कि गड़बड़ा गया।
अंजना दी प्रणाम।
हाँ प्रणाम। I think it's time now.
Yes. प्रणाम आभा दी।
हाँ खुश रहो। प्रणाम प्रमिला मैडम।
प्रणाम, खुश रहिए।
प्रणाम मैडम।
प्रणाम आभा दी।
हाँ हेलो, प्रणाम प्रणाम।
प्रणाम आभा दी।
हाँ खुश रहो, खुश रहो।
गुड इवनिंग आभा मैडम। गुड इवनिंग।
गुड इवनिंग। हेलो चारू।
गुड इवनिंग आभा मैम।
हाँ लॉन्ग टाइम, बहुत दिन बाद आज चारू को देख रहे हैं। वसुंधरा, रेखा, सबको हेलो।
हेलो
मैडम, गुड इवनिंग मैडम।
हेलो आभा दी, हमारा म्यूट किया हुआ है
मैडम।
कविता, गुड इवनिंग।
मैडम सभी को। तो हड़बड़ी हो जाती है, ये टाइम थोड़ा सा सूट नहीं करता है, भागो के आना पड़ता है।
आई थिंक प्रमिला दी मुझे पहचानती नहीं है वैसे। आई थिंक सो।
मैडम गुड इवनिंग।
तुम अपने आप को इंट्रोड्यूस करो रेखा, प्रमिला मैडम को विश करो।
प्रमिला मैडम का आई थिंक इंटरनेट इंटरनेट जो है अभी चल रहा है कि नहीं, आई डोंट नो।
चल रहा है
चल रहा है, बड़े स्माइल
मैं
कर रही
सबको
है।
देख रही हूँ, मैं सबको देख रही हूँ, अच्छा लग रहा है।
मेरा नाम है डॉक्टर रेखा झा। मैं अंजना दी और आभा दी से 1 साल जूनियर थी पीएमसीएच में, एंड आई वाज वन ऑफ द फर्स्ट पेशेंट ऑफ डॉक्टर आर.के. मोदी फॉर desensitization.
Is it?
He knew me very well because I was the guinea pig. I was one of the patients.
Getting all the shots.
But it worked. It really worked.
And Abhi, she is president of Bhagalpur Society, Pramila Di.
Yeah, she is very active,
वो
very
सब
active.
तो दूसरी बात है, अभी तो मैं पुरानी बात याद दिला रही हूँ, क्योंकि मैं रोज रोज जाती थी इवनिंग में आफ्टर कॉलेज टू गेट दैट इंजेक्शन, इसीलिए मैं बोलने लगी।
हेलो
और सर हमसे भी थे, एलकेपी में बहुत हम रहते थे, इसीलिए।
तो बिलेटेड हैप्पी बर्थडे प्रतिभा।
थैंक यू मैडम। कैसी है? अच्छा, हैप्पी
Good
बर्थडे
evening.
गुड इवनिंग
Good evening, Pratibha and Kavita.
यस, गुड इवनिंग मैडम, नमस्ते।
And belated happy birthday, Kavita.
थैंक यू सो मच
Pratibha.
प्रीति दी को प्रणाम, प्रीति दी को प्रणाम।
प्रणाम।
प्रतिभा, प्रणाम मैडम, प्रतिभाला मैडम।
प्रीति दी।
गुड इवनिंग मैम।
कैसी हो प्रतिभा?
थैंक यू मैडम, ठीक है, आप कैसी है?
हाँ ठीक हूँ।
घर पे? कहाँ पे?
हाँ घर पे है, देखो ना, रूम बेडरूम का ये। विनीता कैसी हो?
बिल्कुल ठीक प्रीति दी, प्रणाम प्रीति दी।
बहुत दिन के बाद याद की
जी।
प्रणाम
नहीं,
प्रीति जी।
हमेशा याद करते हैं।
अरे रंजना
जी प्रणाम दीदी।
हाँ खुश हो, तुम लोग को देख के बहुत अच्छा लगता है। आफ्टर लॉन्ग टाइम हम लोग, प्रतिभा से तो खैर भेंट हो जाती है, पटना वालों से कनेक्शन मेरा बहुत ही हो गया। चलो, और यहाँ तो रांची में इतनी ठंड है ना, क्या बता, देखते हो मेरा गला एकदम गला बैठ जाता है।
अच्छा लग रहा होगा प्रीति दी, सो नाइस, इतना अच्छा क्लाइमेट।
सब लोग यही बोल रहे हैं।
हम लोग तो इतनी गर्मी है कि मत पूछिए, सो ह्यूमिड एंड हॉट, बहुत गर्मी
बोली मेरी बहन है ना बोरिंग रोड में, बोलती है कि हम लोग तो यहाँ तो जानती है, रात में हम लोग ब्लैंकेट ओढ़ते हैं और दिन में हल्का।
यहाँ बहुत गर्मी है,
बहुत गर्मी ह्यूमिड है, सही
मैं भी जहाँ हुआ बड़ा अच्छा मौसम है।
आ जाओ, खुश रहो, खूब यहाँ फॉल उल में खूब भीड़ है, सब घूमते हैं, घूमने
चलो
की जगह
हम लोग सब चलते हैं रांची।
एकदम जाना चाहिए।
जानी तुमको हम याद कर रहे थे।
एकदम प्रणाम मैडम। वर्चुअल बैकग्राउंड ऐड करने के चक्कर में इधर से उधर हो जा रहा है, अब छोड़ दे रहे हैं इसको।
हेलो डॉक्टर निभा मैडम।
हेलो सबको हेलो, मैडम लोग को प्रणाम।
Can we start? I think it's 5 o'clock, Supriya.
या
शुरू किया जाए।
तो राकेश जी,
यस मैम।
हाँ अब शुरू करते हैं हम लोग।
जी मैम।
ठीक है।
और विंटर पट्टा में सब लोग ठीक ठाक है?
सब ठीक है प्रीति दी, सब बढ़िया।
कोरोना तो मत पूछो, क्या हालत कर दिया। यहाँ तो एकदम कूल वेदर, फैन ऑफ करके बैठे हैं, सोचो।
So we start. I think is it live now?
Yes ma'am, it is like.
Now can I start?
Yes, Anjana, you start.
Okay. A very good afternoon to all the members of Patna Obs and Gynae Society as well as Bhagalpur Obs and Gynae Society. Today I welcome all my teachers, seniors, juniors in this webinar on auspicious occasion of Breastfeeding Week, and it's World's Breastfeeding Week. I'm very glad that the Bhagalpur Society has joined hand with us in this webinar. We have learned speakers today and we are lucky to have them on this platform. The first talk is by Dr. Sneha Buyar, who is the chairperson of Breast Committee Foxy. Our second speaker is Dr. Charu Modi, third speaker Dr. Basundhara Lal, and fourth speaker is Dr. Arjun Agarwal. Our learned chairpersons are Dr. Vinita Singh, Dr. Preeti Bala Sahai, Dr. Poonam Lal, Dr. Kavita Barnawal, Dr. Pratibha Singh, and Dr. Supriya Jaiswal. And I shall introduce as we progress in the program further. Now we shall proceed for lighting of the lamp, which symbolizes spread of wisdom and knowledge.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now the theme of breastfeeding for 2021 is Protect Breastfeeding, a Shared Responsibility. Now I request Dr. Vinita Singh, President POX, to give her welcome address. She is Associate Professor in NMCH, Consultant at Care Hospital.
Show the
Patna.
CV.
Committed for the society, she has held many positions in the FOXy as well as in POX, and was organizing secretary of NICON 2019. Dr. Vinita Singh, you are welcome for your welcome address. And
Thank
over
you,
the mic to you
for such a wonderful word, Anjana Ji. Very good evening to all respected seniors, friends, and juniors. We are society celebrating World Breastfeeding.
Vinita Di, you are mute. Vinita Di, you are mute.
You're okay. Sorry. Thank you very much, Dr. Anjana, for such a wonderful word. Very good evening to all of you. Respected seniors, friends, and juniors, we are society celebrating Breastfeeding Week along with joining hands with Bhagalpur Obsangani Society. And through this webinar, we will be highlighting the importance of breastfeeding by eminent speakers. I am really feeling proud and honored to welcome Breast Committee Chairperson FOXy, Dr. Sneha Bhuyar, who has done a tremendous work pan-India regarding breast problem and importance of breastfeeding. I would like to congratulate Dr. Sneha. She is one of my best friends for your contribution as chairperson in FOXy, which is being appreciated by so many FOXians. Once again, I welcome you as guest speaker. I also welcome my very own dear Dr. Charu Modi, who is chairperson of Adolescent Committee, Patna Obsangani Society, Dr. Vasundhara Lal, past secretary, Bhagalpur Obsangani Society, and Dr. Arjun Agarwal, associate professor of surgical oncology department of Medical College and Hospital Bareilly, UP, as guest speaker in today's webinar. I also welcome from core of my heart, teacher of future, past president Ranchi Obsangani Society, Dr. Preeti Bala Sahai, Dr. Poonam Lal, who is chairperson of Breast Committee, Patna Obsangani Society, Dr. Kavita Barnawal, secretary of Bhagalpur Obsangani Society, Dr. Pratibha Singh, national coordinator of IAEC FOXy, Dr. Supriya Jaswal, my beloved secretary of POGS, Dr. Rekha Jha, who is dynamic president of Bhagalpur Obsangani Society, and Dr. Leena Nair, treasurer of Bhagalpur Obsangani Society, for chairing today's very important sessions. I also welcome all my office bearer and office bearer of Bhagalpur Obsangani Society, as Dr. Pragya Mishra. I think she will be joining shortly. Dr. Nibha Mohan and Dr. Anjana Sinha, and all who has joined in this webinar. I also welcome from core of my heart all my seniors, past president, patrons of society, Dr. Pramila Modi, madam. Pranam to you, madam, for joining this webinar. I also welcome Dr. Abha Rani Sinha, Dr. Kumkum Sinha, she will be joining shortly, and all my friends and juniors. Last but not the least, I welcome pharma partners. Thank you very much. Over to Dr. Anjana Sinha.
Anjana, unmute yourself. Mr. Rakesh?
Yeah. Yeah, I have been muted from that side only. Now I have unmuted. Now thank you, Vinita, for your inspiring words. Now I request Dr. Rekha Jha, President of Bhagalpur Society, to address the August gathering. She is consultant gynecologist at Bhagalpur and was secretary of Bhagalpur Obs and Gynae Society in 2002, and she was secretary of IMA also in 2003, chairperson of Public Awareness Committee, BOX. Dr. Rekha, you are welcome.
Thank you, Dr. Anjana. For some time, I am having this internet issues. So, am I audible?
Yes, you are.
Okay, thank you. So, from I'm having some trouble. Wait.
Yeah, actually, have you logged in by your mobile also and with your laptop too?
Yes, yes.
Yeah, that is the problem. You please off one of your device.
Okay. So it is very dark because there is no light here. Anyway, so thank you, Dr. Anjana, for introducing me, and thank you, Dr. Vinita Singh and Dr. Supriya Jaiswal, for joining hands with Bhagalpur Obs Gynae Society for this very well meaning webinar on breastfeeding, because it is the breastfeeding week, and I think I should only introduce my seniors or hold my hands in front of them, like Dr. Pramila Modi, Dr. Preeti Bala Sahai, Dr. Abha Rani Sinha, Dr. Anjana Sinha, and there are so many here who have joined. I welcome everybody, each and everybody of them, especially the speakers who have taken time and prepared. Now I welcome Dr. Sneha Bhuyar, whom I can see now, because there was a problem with my internet, madam. And I personally don't know you, but soon I think I will know you much better. And thank you for giving time for this webinar with the Patna Obs Gynae Society and Bhagalpur Obs Gynae Society. And my welcome to all my members and all the speakers who have been introduced by Dr. Vinita Singh. They are, as you know, Charu Modi and Dr. Vasundhara Lal and Dr. Arjun Agrawal. And I think there is one more speaker.
Dr. Sneha, madam. She is there.
Dr. Poonam.
No, Dr. Charu Modi.
Okay, Dr. Charu Modi. Sorry, Charu. Sorry. So,
Poonam is chairperson.
I welcome the speakers to this August gathering, and I wish you all the good luck so that you carry on the speeches very nice. And Charu, I'm really very sorry because of the problem in the internet.
No, ma'am, it's okay.
Struggle right
Thank
now,
you so
much. So you please forgive. And,
Thank you.
Again, I hand over the mic to Dr. Anjana Sinha to carry on.
Now I request Dr. Supriya to kindly show the message of our Foxy president.
Yeah, good evening, everyone. I'm really very happy to be having this program of Patna OB-GYN along with Bhagalpur OB-GYN Society. Thanks to Dr. Rekha, madam, and Dr. Kavita Bardwan. There's a message for Breastfeeding Week from Foxy President, Dr. Shanta Kumari, madam. She has actually sent the video to all. Whoever is doing the Breastfeeding Week celebration before the CME, we are going to display it. So just see. Mr. Rakesh? Yeah, this is the message by Dr. Shanta Kumari.
Dear friends and Foxians, greetings from Foxy. We come to you with the theme Foxy for all always and Dhira stop violence against women. The World Breastfeeding Week is celebrated from the 1st to 7th of August every year. And this year, they come with the theme Protect Breastfeeding, a shared responsibility. Foxy stands for all mothers and newborns. Foxy is celebrating the World Breastfeeding Week, and we urge all members to participate in this initiative. Data says that India is lowest among the South Asian countries. Only 44% of our mothers initiate breastfeeding within 1 hour of delivery. And it's our responsibility to see that we increase this number of women who breastfeed their babies immediately after delivery. And WHO has identified that poor infant feeding practices contribute to the neonatal death. And this is something which we have to look into. Friends, when you see the data, almost 53% of pneumonia and 55% of the diarrheal deaths among the neonates are because of the poor breastfeeding habits and where the baby is not being exclusively breastfed. So we urge everyone to see that the mother gives exclusive breastfeeding for the first 6 months of the life and continues the breastfeeding for almost 2 years. This is the only way we can ensure that the neonatal health is maintained. Friends, breastfeeding is not only important for the baby but for the mother also. We know it contributes to the mother to get back into shape. It has a role as a contraceptive and has been shown to reduce the risks of some of the cancers too. It is an emotional connect which bonds the mother and the baby. And it's a beautiful experience which we all have to nurture. Friends, we always tell our mothers that they need to take care of the babies. But it is not only the mother's responsibility, it's the responsibility of the whole family, the whole society to ensure that the mother is given the support needed to ensure safe breastfeeding to her baby. So friends, I urge you all to increase the awareness programs in your hospitals, in your societies, and send across the message that we need to protect breastfeeding as it is a shared responsibility of every one of us, doctors, healthcare providers, the families, and the society at large. Let's get together.
Thank you. Over to Dr. Anjana Di.
Thank you, madam, for such nice words for breastfeeding. You have actually highlighted the theme of 2021, Protect Breastfeeding, a shared responsibility where we all are concerned and we should take the responsibility to see that the babies are breastfed within first hour of the delivery. Now, taking the program forward, I request our chairpersons for the first.
Anjana Di, you got muted again. 1 minute because
they are muting me from that side.
Yeah. Please, there's a request. All of you, please keep your audio muted because only the person who has to speak should keep it unmuted. Shell Bala Srivastav, somebody. Rakesh ji, please.
There is some problem.
Oh.
Rakesh ji, you mute everyone except Dr. Anjana Sinha.
I would like to thank our president, Foxy President, Dr. S. Shanta Kumari, for highlighting the 2021
Unmute her. आप खुद unmute कर लीजिए. अंजना दी again muted.
Oh, उधर से कर दे रहा है.
Yeah, because of the noise. Now continue.
Now, I must thank our president, Foxy President, Dr. S. Shanta Kumari, for highlighting the theme of 2021, Protect Breastfeeding, a shared responsibility. Of course, it is our responsibility also to see that each and every infant, which is, they should get breastfeeding within an hour of their delivery. Now, carrying the program forward, I request our chairpersons, Dr. Vinita Singh, our dynamic president, whom I have just introduced, a very hard-working person and caring for all the members of the society. So, Dr. Vinita, you are welcome. Our second chairperson is Professor Preeti Bala Sahai, ex-professor and HOD Department of Obs and Gynae, RMCH Ranchi, senior consultant and visiting at Health Point Hospital and Jagannath Hospital, Ranchi. She is past president of Ranchi Obs and Gynae Society, and she is the key person of starting EMOC in RMCH. And she is an invited faculty in national and international Foxy conferences, and she has many publications in national and international journals. Preeti Di, you are welcome. Now handing over the mic to the chairpersons to carry the program forward. And for the first talk by Dr. Sneha Buyar.
Thank you, Anjana, for your kind words. A very good evening to all, and I welcome all of you in this webinar on the breastfeeding week. We know every year we are celebrating this breastfeeding week from 1st to 7th August. Everybody knows. And the speaker that she's going to speak, that is Sneha Bumia. I know her when I was visited in Indore on conference on the breast,
CV of Dr. Sneha
breast disease. Huge and a very great, grand success conference organized by Dr. Kavita Bapat. Nobody knows only on the breast. There was 3 days conference. It was so nicely arranged, and every speaker, panelist. I was also one of the faculty. So Dr. Sinha, I know her very well. She's a very talented and a smart lady. Now I'm going to speak a formal introduction of Dr. Sneha. That is, she's chairperson study on the Female Breast Committee 2009 to 2021. She's a governing council member, ICOG 2021-22, associate member of Royal College of Obstetrics and Gynecology. She's a managing director, Sukharta Hospital. Her nursing home is Sukharta Hospital. With 29 years of this experience, she's government medical college and the private practice also. Delivered more than 300 talks in the state, national, and international levels, 25 articles in national publication, and many more. National awards of FOXY. The one important, that the MS International Signature Award for Phenomenal Leadership 2020. And this year I am going to take that award. She's a Lokmat Excellence in Healthcare Award, FOXY Award Expert, and trainer of the National Adolescent Trainer FOXY, National Advisor GPNI, President, Organizing Chairperson, Pretty Care 2018, and she's a life member of FOXY and Menopausal Society, IMA, and many more. Ongoing research on menopause, cancer, cervix. And with these words, I am inviting Dr. Sneha. She's going to speak a very, very important, that is everything about the breastfeeding, everything. A very practical approach and the practical guide. Dr. Sneha, please.
It's always Dr. Sneha to see you as a speaker. She is going to speak on very important topic, everything about breastfeeding, a practical guide. We all know that breastfeeding is so important. That's why we are celebrating World Breastfeeding Week every year, starting from 1st of August to 7th of August. It's our duty to make aware to all women to go for breastfeeding. That is not only important for mother, but important for baby, very much important for baby, and it's give a very emotional attachment to both. So how it is important for baby and mother, we will hear from Dr. Sneha. So over to Dr. Sneha Priyar.
Thank you so much, Dr. Vinita and Madam Priti Bala Saheb, for that kind introduction. And thank you so much, each and every one of you, for this warm welcome. Always, Patna Society and all the respected seniors and all our dear friends, I'm very happy to be with you all. And with this, I just quickly start my topic, as I know I don't want to tell you all how busy I am, but I don't want to waste your time also. So I just start with my topic, today's topic, everything about breastfeeding, not only the problems. We start with the basics of breastfeeding. And this year, as you have already said, the protect breastfeeding, a shared responsibility. That is what we are stressing on, and we are working on this theme as well. So just now you have heard the video on, you have seen the video on this theme by Dr. Shanta Kumari.
Slide show.
Yes. I think it's been done already. Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. So I would just start with this, that breastfeeding is actually a natural instinct of every woman, I would say. Like how every mother has a dream to become a mother, and she, of course, has a natural instinct for breastfeeding. Though it appears a very, very simple act, it is actually a complex neurohumoral reflex. For the layman, it is just, getting the baby attached to the breast and immediately the milk flows. But actually, there is a sensory impulse which is traveling to the posterior pituitary, where there is a release of oxytocin and prolactin. And this oxytocin is responsible for the milk letdown for that particular feed. Whereas the prolactin, which is secreted at the background, it is responsible for production of the milk throughout the day and night. But the prolactin secretion is maximum at night. And that's the very reason the milk secretion is also maximum at night. And yes, of course, all of you are very, very experienced mothers as well as obstetricians. And you will all agree to me that this is definitely emotionally controlled event. And that's the very reason the mother should be, physically and mentally healthy. The moment she feels that her baby is hungry, the moment she hears a baby is crying, or even maybe just the sound of the baby, sometimes even the loving thought about the baby, that also can lead to this oxytocin reflex, and her milk may start flowing. That how it is emotionally related, and that's how it is related with the sound status of the body and mind. And that's a very reason anything which makes her worry, anything which is painful, any physical or mental stress, any doubt whether she'll be able to feed her baby, whether the milk will be sufficient or no, all these worries and doubts may, hinder this reflex. And that's why we have to counsel her and counsel her that how important this breastfeeding is for her baby, to herself, to her family, and of course to the nation in total. So we have to stress on what are the benefits of breastfeeding for her baby. Breastfeeding, actually breast milk is basically a complete food for that baby, for all the babies rather. It has got all the constituents of food in appropriate quantity. It helps in gastrointestinal as well as immune system development. It helps in cognitive development of the baby. The baby's IQ is proved to be at least 8 points higher than the non-breastfed babies. And definitely the babies who have, they are breastfed, they have reduced risk of infection, reduced risk of gastrointestinal problems, the respiratory infections, of course, the skin, the other allergic illnesses like skin diseases, eczema, even the allergic asthma. So all these diseases the baby is protected with. It also, protects the baby from various serious illnesses like Hodgkin's disease, Hodgkin's lymphoma, leukemia, and type 1 diabetes, obesity. It also enhances the maternal and the baby's bond. So that's a very reason. In fact, we not only we as Foxians, but also WHO, UNICEF, IAP, all the other organizations, it's IYC and Infant and Young Child Nutrition, all of them promote early initiation of breastfeeding, that is as soon as possible. How soon we are going to discuss it, but I will just try to say soon after the birth of the baby, as soon as the baby comes out of the mother's womb, you have to put the baby to mother's breast, and you have to start feeding. There's even, you need not wait to cut the cord and clean the baby and dry and all these things. There's no necessity. So soon after the birth. And then, of course, you have to continue this breastfeeding exclusively for first 6 months. By exclusive, we means not even water. Exclusive mother's milk, exclusive breastfeeding. And optimum breastfeeding for 2 years has to be continued with complementary feeding, which should start after 6 months of life. No, it's not only beneficial to baby, we are all the time saying, so how is it beneficial to the mother? Because as all of you know, there is release of oxytocin, which is necessary for uterine contraction. And so the earliest the baby starts feeding, you know, even before the separation and expulsion of placenta, if the baby is attached to mother's breast, it's going to help you control the postpartum hemorrhage. It's going to help you for involution of uterus, and that's a very reason even the incidence of sepsis has been found to be less. Long-term breastfeeding helps in loss of the excess weight which she has acquired during pregnancy. Prolonged breastfeeding will, you know, prevent ovulation and will act as a natural contraceptive whenever she is on exclusive breastfeeding. There are long-term documented effects as far as the protective effect on the breast, ovarian, and endometrial malignancy is concerned. As it reduces, you know, the efforts by the mother for getting the milk, boiling it, you know, purifying and cleaning the utensils, it saves her time, it saves economy as well. It saves the economy of the country by, you know, minimizing the visits to the pediatrician, because the baby is not facing all these problems of diarrhea, dysentery, and vomiting. It saves the country's economic by, you know, $14 billion every year, approximately 98,000 crores rupees. That high is the toll on the economy. So that's the very reason we are supposed to, you know, promote breastfeeding. Now, just in short, I will just finish up this colostrum, transitional milk, and mature milk. So colostrum is actually the initial milk which is produced during the later stages of pregnancy, towards the end of the pregnancy and up to first 4 days. This is very, very rich in proteins, calories, and antibodies. Whereas transitional milk, which is produced from day 4 to day 10, is a little low on proteins, but in comparison to colostrum, but definitely it is very good. And the mature milk is from day 10 onwards, till termination of the breastfeeding. Now, what are the problems? What are the factors which can lead to inhibition of breast milk secretion? As I have already talked, of course, the psychological aspects of the mother, whatever pain, discomfort, stress she has. Apart from that, if there is an improper latching, improper and inadequate lactation, this is because of the delay in the initiation. If you don't attach the baby to the mother's breast, definitely it's going to, you know, not going to initiate breastfeeding effectively. And that's why early initiation soon after birth with good effective latch. If you do this, it's going to be very, very effective breastfeeding, and you will not have any problems as far as inadequacy or failure of lactation. If the lactation, that if the attachment is poor, then definitely, you know, only the nipple. What do you mean by good attachment? It's the part of the nipple and areola should go inside the baby's mouth, and not only the nipple. So if it is not correct, then definitely the mother is going to face these problems of sore and cracked nipple, fissures of the nipple. She's going to face very, very pain during feeding, and because of this, she will, you know, try to avoid feeding. Because of this, she will have engorgement, stagnation of milk, infection leading to mastitis, and ultimately breast abscess. So all these are the sequence of events, you know, which follow if you do not initiate breastfeeding early with good attachment. Sometimes, you know, the mother is unexperienced. Maybe this is her first baby, or maybe even for previous baby, she has, you know, done bottle feeding. So she's not very experienced. So she can use bottles. The mother who is having, you know, either the what you say retracted nipple or flat nipple, she feels that maybe she's not able to feed with this, the baby is not going to attach, or baby is small, sick, and not going to suck properly. So in this, there is a role of obstetrician as well, and even the staff nurses, and of course the family members. So you need either the skilled support initially, which is to be continued by the family members, and that's what we are talking about, the shared responsibility this year, that as an obstetrician, it's not only to deliver the baby, but we have a responsibility of initiation and continuation of effective breastfeeding for this baby. So what are the barriers to breastfeeding? Though breastfeeding is the optimal source of nutrition and human milk is very specific, it provides all the essential nutrients to the baby for its growth and development. It is scientifically mediated reflex, as we have already said, but because of this, late initiation, lack of experience, and lack of confidence, of course, the most important, lack of support by the healthcare workers, healthcare providers, and by the family, the woman lands up into further, doubt and worries, and she doesn't feed the baby. Now we have seen that we have to start breastfeeding as early as possible with good effective latch. Now, how should be the mother's position? Here in this picture, you can see there are various positions: cradle hold, cross cradle hold, football hold. But I will just show you all the positions. This is the cross cradle hold. This is the Australian hold, where the mother is, vertically holding the baby and trying to attach to the breast, and sideline. Now, about this position, I would not suggest you that any of the position is superior over the other, but it just tells you that in whatever position you are comfortable, you should feed the baby. May it be sitting or a sideline position. Previously, there was a myth that, if the mother is feeding the baby in sideline position, the baby can aspirate, but this is not true. If you are comfortable, the baby is comfortable with skin to skin contact, if you are feeding the baby with good effective latch, this is what I mean by latch. In this right side picture, you see only the nipple going inside, where the baby can squeeze the nipple and it can crack. Whereas on the left side, you can see nipple and a part of areola should go inside the baby's mouth. That is good effective latch. Okay, so what are the barriers to breastfeeding? Lack of confidence of the mother, belief that the breast milk is not sufficient, lack of adequate support system, may it be from health worker side or family side, history of previous breast surgery. So she has a doubt that yes, maybe she won't be able to feed. And of course, what we have said just now, breast engorgement, where the breast has become so tense and tender that proper latch is not possible, and cracked and sore nipple, which makes the breastfeeding so very painful for the mother. We are all the time stressing on this fact that breastfeeding should be a pleasure, an enjoyable experience. But if the mother has this painful situation, she will not be able to feed her baby properly. And that's the very reason we should make sure that there should be no doubt, no stress, and no pain to this mother. All mothers in the world should breastfeed their babies. There's no absolute contraindication, except situations like where the mother is on anti-malignancy drugs or radioactive isotopes. These are the only two conditions where the breastfeeding is contraindication, and one more condition where the baby has the inborn errors of metabolism like galactosemia and all these things, where the baby cannot tolerate the mother's milk. Even for HIV positive patient and patients of active pulmonary tuberculosis who are already on treatment, they can definitely breastfeed their baby. As far as the COVID situation is concerned, if the mother is COVID positive, but if the mother is COVID positive, she can still breastfeed her baby, like any other woman. Now, how this is so? It has been proved beyond doubt that though there is a possibility of vertical transmission of COVID, it is not observed in the breast milk. It is not present in the breast milk, and that's a very reason breastfeeding per se is not going to transmit to her baby. But if she is comfortable, able to take care of herself with proper respiratory hygiene and hand hygiene, she should be able to breastfeed her baby. If she is not well, she's not able to take care of herself, somebody, some caretaker who is COVID negative, with all these precautions, hand hygiene, respiratory hygiene, with proper mask wearing by all the persons who are present there, and definitely with the proper hygiene for the breast pumps and the utensils, she can definitely breastfeed her baby. So there is no contraindication even for COVID positive mother. Now, what are the good breastfeeding techniques? As we have already talked about what should be the position of the mother, it should be a comfortable position to the mother. By comfortable, we mean that she should be, supported properly, and she should be at rest, maybe with a backrest or sideline position. She should expose her breast to the baby properly, should not feed through the chains, chain gowns, which nowadays majority of the patients they are using. The baby, how should be the baby's position? The baby should be positioned in such a way that the baby should have a direct skin to skin contact with the mother. Baby should be directly facing towards the mother. It should not be, the mother is lying in sideline position and baby is lying in a supine position, and you are trying to twist the baby's neck. So the baby is not comfortable, so baby will not feed properly. So that's how mother's position should be a comfortable position by these various position which we have seen. Baby's position should be comfortable position with a backrest. The mother can support the baby's back with her own arm, forearm, and then make the baby turn to her side, and then you try to attach it to the mother's breast. Now, how do you attach? Suppose sometimes the baby doesn't open the mouth properly. So only the nipple goes, part of the nipple goes inside. So what you have to do is, you have to touch the mother's nipple to the baby's nose. So in search of the nipple, the baby opens her mouth widely, and the nipple and part of the areola goes straight inside. So that is how you achieve a good effective latch. Now, how frequently you should feed the baby? There are two schools of thought. One is a scheduled feeding, and second is demand feeding. So scheduled feeding is you advise the woman to feed the baby every 1.5 to 2 hourly. But sometimes what happens, if the baby is feeding properly and goes to sleep for 2-3 hours, we may have to unnecessarily disturb the baby. That is not right. So schedule, very strict schedule is not recommended. On the other hand, you have demand feeding. Here, baby, you feed the baby whenever it cries. But the baby can cry for anything, maybe just the pain in abdomen, maybe the baby just wets the bed. So the various reasons. So for every reason, if you keep feeding the baby, it will be too much for the baby. And suppose on the other hand, you have a sick baby, a weak baby who cannot cry, and so that baby will be in fact neglected, and the baby can land up into hypoglycemia. So you have to have you have to optimize both this schedule and demand feeding. So preferably 1.5 to 2 hours, especially you have to recognize the hunger cues of the baby, and then you have to feed the baby. Now, how do you know whether the feed which the baby is taking is adequate for the baby? If the baby is consuming a good amount of milk, you can say, if the baby is sucking for 10 to 15 minutes every 1.5 to 2 hourly, and if the baby is sleeping well after every feed, if the baby is passing urine 4 to 5 times a day, and if the baby is gaining weight, definitely the feed is sufficient. So that's how you have to know that how the baby is having, sufficient feeding. Now, I would just like to have this some of the cases I have this. You have a case, suppose you have certain practical situations where you face, so you have a patient, para, just delivered, and she's complaining of blood stain discharge. So how do you examine this? You have to examine her breast. You have to see that whether there is any lump and what kind of discharge it is. If it is a blood stain discharge, you have to localize whether it is from a single duct or from multiple duct. If there is a lump, then you have to go for, of course, investigations. I would just tell you that many of the women who are feeding for the first time, the para one usually, they do have this blood stain discharge even towards the end of pregnancy and during first few days of breastfeeding period. Definitely, if it is, if it is disappears after continuation of the feeding, then you need not worry if it is not associated with breast lump. If there is a breast lump, you need to investigate this woman with ultrasonography, cytology of the discharge, and galactography. Because the only thing is you have to rule out duct papilloma and rarely the cancers which are associated with breastfeeding. Sometimes you have the patients who are, they are having either crack or sore nipples. These are the conditions where the mother has painful breast. So where you have inverted nipple, flat nipple. So in this situation, the feeding becomes difficult and the breast becomes engorged. Sometimes just by wrong type of latch, the nipple gets cracked and she has this painful breast. So she, just refuses to, or she avoids breastfeeding. So she has engorgement, and with further continuation of this sequence of events, she gets mastitis and breast upset. Just to show you some of the pictures, you have this flat and inverted nipple here. But it is not true that she can't breastfeed, because as we are describing all the time, that the baby latches or attaches to the breast. So nipple in part of the breast, the part of the areola goes inside. So even if you see a woman like this during antenatal period, you're not supposed to, tell her that yes, you have these problems. She will unnecessarily become anxious, because even the women who are having these kinds of problems, there is automatic correction by the nature itself towards the end of the pregnancy. With physiologically, there is automatic correction. But sometimes, even if it remains so near the delivery or just immediately after delivery, you can go for manual correction, maybe little syringing, you can go for correction. But during antenatal period, you have to just mention on your paper, and you need not, go for, you need not tell her that yes, you have this problem. And definitely the baby attaches to the breast per se, not to the nipple. So sometimes you can land up into this, engorgement of the breast. And why this has happened, I have told you that if you have delay in starting the breastfeeding, if you do attach the baby with poor attachment or wrong type of attachment, if some people have the myths that she is supposed to feed the baby for only 10 minutes or 5 minutes. So because of infrequent and incomplete or restricted feeding, you can land up into this problem. So definitely, if you have this engorgement, the only and only treatment what is necessary is you have to continue feeding the baby with good effective latch. And suppose you have this engorgement which is very, very painful. So in this situation, you have to go for hot fomentation before starting the feeding, and cold compresses after starting the feeding. And with this, if you don't relieve her of her symptoms, then maybe you have to counsel her that she need not worry. These are the natural, this is just the natural course of time, and it will be over, and she can breastfeed her baby effectively. Once she is convinced with that, I think most of the symptoms will be relieved with continuation of breastfeeding. If baby's mouth is the most effective pump you can have, and that's the very reason, gently if you massage her breast and put the baby to her breast, she's going to be relieved of all the symptoms. But if she doesn't, then maybe you have to do what is called as, if the baby is not with her, not feeding well, then maybe you have to do this manual expression. So gently you massage her neck and shoulders, then you gently massage the breast, to just to allay her anxiety. And with these 4 fingers below the nipple and thumb above, you have to gently squeeze it. So that is how. If that is also not possible, then maybe you have to use these breast pumps which are available as manual, battery operated, and electric pumps. So after the feeding, you have to do cold compresses with either the ice packs or maybe just the cabbage leaves as it is shown here. So these are the pictures of sore nipple, which I have told you that if the latch is not correct, If nipple and the areola, this complex is not going inside, then definitely you'll end up with these problems of painful cracked sore nipple. And what you have to do is, you don't have any specific treatment for this also. Just do gentle massage and constantly or continuously you continue feeding. Maybe just a little soothner or ointment you can apply, but you just apply her own milk and let it air dry. That is what the treatment is for this patient also. Sometimes you have these pictures, you can have either this breast of very angry red appearance, or maybe you have this little swelling and red appearance, or you can have just normal appearance of the breast, but she is complaining of very severe deep penetrating pain or burning sting, insect bite like sensation she gets. This is nothing but the candidiasis or thrush infection of the breast. This is also seen very often where the baby may be having oral thrush. So the treatment of this, you have to diagnose this and treat it accordingly. So naturally the mother has to receive systemic antifungal and maybe vaginal pessaries, and at the same time she has to apply the gentian violet or maybe antifungal ointments locally, and the baby's oral thrush has to be treated simultaneously. So with the continuation of this engorgement, you can have, the patient can progress to this swollen, edematous, red, painful breast. So that you have to, you all know what is mastitis, and this is just the continuation of these problems. And you have, once again, antibiotics, anti-inflammatory, hot compresses or hot fomentation before feeding, and continuation of proper feeding with good attachment, and then cold compresses after the feeding, that will solve her problem. If this doesn't resolve, then of course this patient is going to land up into what is called as the breast abscess. She may have localization of the symptoms, and she can have a lump, very severe painful throbbing pain she will have, a breast abscess like this. So if this breast abscess is very superficial, pointing like this, maybe you can definitely drain this. So pus anywhere in the body has to be drained out. But for this patient, definitely, we have two schools of thoughts, because for this breastfeeding woman should not go for incision and drainage, what we have been doing over the years. The moment you diagnose this breast abscess, you refer this patient to the surgeon, and you get relieved of your duty, but that is not correct. What you are supposed to do is give antibiotics, anti-inflammatory, hot fomentation, continuation of breastfeeding, and then you try and do what is called as needle aspiration for these women. If it's a small abscess, at single sitting you can definitely drain all the pus, but even if it is a larger abscess, with repeated drainage with the needle, you can definitely relieve her of the symptoms. If you do incision and drainage, you must have seen, I'm sure you refer to surgeon and your surgeon does incision and drainage, and a large cavity is there which he asks you to pack or do dressing daily. That takes 2 to 3 weeks, and in that situation, maybe you have to go ahead with lactation suppression, which is in fact very detrimental as far as this breastfeeding promotion and all this what we are talking about, the benefits to mother and baby. So if it is a deep-seated abscess, you may have to go for this ultrasonography and guided needle aspiration. Definitely there is evidence, what Cochrane database has said, that both the methods, the incision and drainage and the needle aspiration, they are equally effective as far as the treatment of breast abscess is concerned. And it's not proved beyond doubt that which one is superior, because these are the smaller studies. But definitely, if you consider the benefits of needle aspiration, there is no surgery, no anesthesia, no open wound, so that the pain is definitely not there. She's relieved of the pain, and of course she can continue breastfeeding, which is the most important advantage for all of us. as obstetrician also, and to the feeding mother and the baby also. So with this, I hope I have covered most of the aspects of this breastfeeding, the subject, which is so very close to our hearts. We as obstetricians are privileged. We have this opportunity to explain everything to her. We have this opportunity to support her also, and we be the angel, maybe just the mediator for this, pleasurable experience. So thank you so much. If you have any doubts, I'll be very happy.
Thank you, Sneha. Nicely, you have explained everything about the breastfeeding, everything about the diseases, positions, timely. Timely, you have very much explained that not the when the baby will cry, time should not be fixed. Every time the baby will on demand, we should give. And so nicely, one question from my side is not question or suggestion. You can say sometimes mothers and baby both are feeling very much trouble in problems when the nipples are very big and black nipples, and both nipples are very big. Most of the thing I have seen in the when I was giving the postnatal around in the ward rooms, ma'am, the baby lay nahi raha hai mouth. So then what in this condition, what you will do? The nipples are very big. The baby is crying but not going to their mouth. And mother was also very difficult because there is a full of milks in the breast. Breast is very tender, mastitis. Then how you will manage or
I
what you will
think
do?
the nipple is very big. That's a myth by the mother. Myth for the mother, because what I have suggested, whenever you're not able to attach the baby's mouth to the nipple properly, what you're supposed to do is you touch the mother's nipple to the nose and make the baby open the mouth wide, so that's how directly you can put the nipple and areola inside. So I don't think, because the same mother, if you had seen the same mother which complains to you on the first day that the nipples are very big, and she is able to continue breastfeeding later on. So it's a myth. Yes.
Baby's mouth is very small and nipple is outside, and baby is going to cry and they can't suck the nipples. Okay, thank you. Just one my suggestion. You are a committee chairperson of the breast feeding. So in the area you are working, तो कुछ pamphlet वगैरह जैसे हिंदी में लिखवा के in village and that Sanya and ladies they are walking in the Anganwadi area. They will distribute.
Yes.
They will.
Madam, we have been doing this across the country wherever our members, they are doing awareness programs, and even for every year we are doing this breastfeeding. Not only the breastfeeding week, we are doing this across India throughout the year. I think Dr. Charu Modi is with us. From Delhi area, Maharashtra also, wherever our members are, we are asking them to, prepare the pamphlets or booklets in regional languages, and they are distributing it to the healthcare workers. So maybe I think for your area also, we can take this initiative up, Charu, and definitely we will go ahead. Thank you for your suggestion, madam.
Thank you. Thank you, Sneha.
Thank you.
Organizers, especially
Thank you,
Vinita,
Dr.
Supriya. Thank you very much, Vinita and Supriya.
Thank you, Dr.
All
Sneha, for your
together.
such a informative and very elaborate talk, and have taken all the aspects of breastfeeding. So it's a very clear message to everyone that breastfeeding should be initiated as early as possible, within 1 hour of delivery or cesarean section. In cesarean section, it may take some time, but within delivery, we can start within 1 year. It should be breastfed feeding should be continued exclusively for 6 months. After that, it should be continued for 2 years. And it is beneficial for both mother and fetus. Fetus is very beneficial, and proper latching, proper positioning is very important. And you have dealt all the aspect in which there is problem of breastfeeding. So how we have to deal those problems, we have dealt it, Sneha. So thank you very much for your talk. Thank you.
Madam, there is a question. Do breasts sag because of breastfeeding?
That
Do breasts sag?
I didn't get the question.
Do breasts sag, but it becomes loose because of breastfeeding?
Sagging of breast.
Definitely not, because all the time we are stressing on this aspect that, breastfeeding disturbs the figure, disturbs the form of the mother, and that's what we have all the time. Yesterday, I don't know whether you were there, Dr. Supriya, we had a sort of a role play, and in that we have, purposefully included one model. Amongst the doctors only, we have had a role play, and one of the model saying, she doesn't want to feed her baby because she is a model and she doesn't want to lose her figure. So in fact, that's how we have convinced her, and how we should convince or counsel our patients. Basically, breastfeeding per se doesn't disturb your form. In fact, if you all agree to me, feeding, whenever there is breastfeeding, the breasts are in fact increasing in the size. The breast during pregnancy and during lactation, they increase in size. So if you continue the breastfeeding, but definitely you have to keep toning them. That's what is the message is. You have to take proper care, because see, this model or whosoever is so health conscious, they're trying to reduce their extra weight gain which has happened during pregnancy. So there is no need for extra efforts, no need for extra reduction in the calories, because breastfeeding per se, it burns extra 500 calories per day. Whenever the mother is breastfeeding the baby, it burns calories. So if you want to maintain the fat and the contour of the breast, you have to consume the specific foods. You have to consume good quality foods. At the same time, you have to do certain exercises, especially the pectoral muscle exercises, which tones up your muscles and which maintains the contour of this. And of course, then toning and massaging is a remedy which you have to do it continuously. But whenever there is change in the size of any organ, even for the skin, we see when it gets stretched and when it comes back to normal, so that definitely it becomes loose. So whenever you have increase in the breast size during pregnancy and lactation, so whenever you stop breastfeeding, the size is going to be little less, because you are not using that organ now. And then at the same time, the skin which was stretched over a larger area, now it is left for the smaller breast. So it is definitely going to have some wrinkles. So stretching and toning, and of course the muscle for the pectoral exercises for the pectoralis muscles. That's how I think we have to go for. And I don't think there is any scientific evidence supporting this, that there is loss of figure or form because of breastfeeding. Thank you.
Vinita Di, with your permission, can I ask a question to Dr. Sneha?
Yes, Dr. Pragya.
Yeah. Dr. Sneha, congratulations for your very clear talk. And this is Dr. Pragya Mishra. And, just 2 days ago, there was a patient.
Hello, ma'am.
Yeah. Hello. There was a patient I saw, like she has stopped breastfeeding. I mean, she's a young patient. She's stopped breastfeeding about 6 months ago. She told me that she had drainage of breast abscess twice, one from the left, so one on the left side, one on the right side. Now, she presented to me with the problem, her right breast, whole of lower quadrant, was quite hard, indurated. It did not feel like a lump, but she said it was quite tender. It was neither an abscess nor like, it didn't seem like a malignant growth or anything like that. But whole of lower breast was quite, it looked reddened and it was indurated and hard. I mean, I've asked her to get a sonomammogram done, and other doctors, she had seen, one person gave her like a course of Megacef, another person gave her a course of Azithromycin. So, she had had courses of antibiotics. So could it be that it has got converted into an antibioma?
Yeah.
Yes, basically now what you are telling, the picture, history and the findings you are telling, I think it looks like, because she has had repeated drainage. So basically fibrosis. She had incision and drainage. So fibrosis and scar, that must be the most, I mean, that we would think it as a first diagnosis. And secondly, of course, if she's having repeated abscess and antibiotics and not responding to the treatment, so antibioma is one possibility. And if of course we can also think of inflammatory breast cancer.
Yeah,
Yes.
exactly.
We have to keep a very
Even
high
I,
index of
yeah,
suspicion. Yes.
yeah. Even I had, in the back of my mind, I was just wondering whether could it be an inflammatory breast carcinoma? Because actually, like it was the whole left and right quadrant of the breast lower part, and it was completely like it wasn't a growth, but it was hard and it was indurated and it was reddened.
Yes. Yes,
So,
that was a very typical history. The patient has a picture like mastitis. She gets a course of antibiotics, anti-inflammatory. She doesn't get a relief. And then, she changes the doctor. Again, she gets a course of antibiotics, anti-inflammatory, and she doesn't get relief. That's how you should suspect that, yes, it can be inflammatory breast cancer. And definitely there is no lump in this cancer. There is no lump. Yes. So it is very classical for this condition that there is no palpable lump. Even when you do ultrasonography, there is no lump. Sometimes it can be missed even on mammography. So only diagnosis is biopsy. Either if the skin, you have some skin lesion, you go for skin biopsy. Or if there is no skin lesion, only hardness, then I think a core biopsy should be the confirmation.
Oh, I mean, FNAC is not going to help if she has. I mean, first, because of the density of the breast, I've told her to get a sonomammogram, and depending on what that shows, then I thought, I'll go for an FNAC. But you're saying that no.
Yes, core biopsy. FNAC we should not do in such lesions. FNAC we should prefer for cystic lesions.
Okay. So how do you take a core biopsy? I mean,
you have to just take if you are not well versed, you can refer to surgeon, but definitely we all as gynecologists can be well versed with this. You have to just take a small needle, but you need a special type of needle for that. It's called as a true cut biopsy needle. So you just put in that needle and just give a thrust. So that gives you a very good biopsy. It's like a strip only, but that gives you histopathological diagnosis, which is a confirmatory.
Thank you so much.
Yes, FNAC most of the times either tells you that only blood, inadequate sample and inconclusive, so it doesn't help you sometimes. For such lesion, true cut biopsy or core biopsy is confirmatory.
Okay. Thank you so much, Dr. Sneha, for elucidating the point. Sorry, I'm unable to switch on my video because there are patients in the chamber. So sorry about it.
Yeah, okay. Thank you so much. Thank you for the interaction.
Thank you. Thank you.
Now, shall we continue?
Yeah, thank you so much, Dr.
There are no questions
and Dr. Supriya. If you, with your permission, I need to leave because I have to join immediately for the other webinar.
Yes.
Thank
Thank you very much, Sneha.
Thank you, Dr. Sneha. Thank you for your elaborate and excellent deliberation, and you discussed A to Z of breastfeeding.
Thank you for coming. Thank you for coming, because in spite of your very, very busy schedule now at present, isn't it, madam? Thank you very much.
And I thank the chairpersons who chaired the session so well. And now moving forward for the second session, we have Dr. Poonam Lal as chairperson, who is a senior consultant at Holy Family Hospital, DNB teacher for last 15 years, consultant Nila Hospital, Joint Secretary IAGE, Chairperson Breast Committee POX. You are welcome, Dr. Poonam.
Thank you.
Our second chairperson is Dr. Kavita Barnawal, Senior Consultant and Laparoscopic Surgeon at Munger, very active member, and she was Clinical Secretary BOX, invited faculty in state and national conferences, contributed chapter in JP books. I welcome you, Dr. Kavita.
Thank you, madam.
Now I request the chairpersons to introduce our second speaker, Dr. Charu Modi, and take the program further.
Okay. Okay. So today we have heard Sneha Bhuyar, madam. She explained well. Thank you, Anjana Sinha, madam, for introducing me and for saying kind words about me. So we today are having a webinar on a very common but still significant topic, that is breastfeeding and mastitis and its complications. So mastitis is very common, as Sneha Bhuyar madam has said, about 13 to 33% cases can land up into mastitis. This is very common, mostly due to duct blockage, because if the nipple is sore, cracked or fissured, especially during antenatal care, when it is not seen, then it can cause mastitis. So now we have Charu Modi, orator of mastitis. She is chairperson Adolescent Committee, Patna Afghani Society 2021-22, chairperson Public Awareness Committee, Fox 2019-20. She was member of Foxy Breast Committee 2017-21 and Young Talent Promotion Committee 2017-18. She was convener Scientific Committee 57th ASCOG held in Patna in 2014 and convener of Ethics and Medical Legal Workshop in 57th ASCOG 2014. She has many publications and added many chapters, and she has been awarded with the Dr. M.P. John Gold Medal Award, Dr. GVLN Murthy Award, Dr. Reddy's Traveling Fellowship, Dr. D. Singh Traveling Award. She has won Best Debater Award in YTP Committee 26 Boston 2018. Her special area of interest is programs related to public awareness, cancer screening, and safe motherhood, as well as contraception. So now I invite and welcome Dr. Charu Modi to head her session. So Charu, the stage is yours. Charu.
Thank you. Yes, ma'am. Thank you so much, ma'am, for the kind introduction. Respected chairpersons, esteemed seniors and dear friends, a very good evening to all of you. Before starting my talk, let me take this privilege of thanking our own President, Dr. Vinita Singh, and Secretary, Dr. Supriya Jaiswal, along with Bhagalpur Obstetric and Gynecological Society's President and Secretary, Dr. Rekha Jha and Dr. Kavita Banwal, for giving me this opportunity to share my talk with all of you today, and it's always wonderful to be associated with Dr. Sneha Bhuyar again. So now coming to my talk, is my slide visible?
Yes, but it is small. Charu, you can enlarge. Yeah.
It is.
I'm sorry.
Yeah.
Just a moment. Is it fine now?
Yes.
Yes. So today I'll be speaking on mastitis following breastfeeding, what to do. Most of my work has been made easy already by Dr. Sneha Bhuyar, as she has covered extensively from A to Z, as rightly said by Dr. Anjana. She has covered every aspect, but still mastitis is very common in lactating mothers, and I'll be speaking on the management part of it. So to introduce mastitis, as we know, is an inflammatory condition of the breast tissue that may or may not be accompanied by infection. It is usually non-cancerous or a benign breast disease, which is often limited to one side of the breast, and occasionally it can be found bilaterally also. But most of the times it is unilateral. Now, there are different types of mastitis. First is the periductal mastitis, which is also known as mammary ductasia. This is commonly seen in menopausal and postmenopausal women and can occasionally be found in men also. Smokers are more prone to this condition, and people suffering from diabetes, autoimmune disorders, or eczema can also suffer from periductal mastitis. Any injury to the breast, like nipple piercing or having implants in the breast, can predispose to development of periductal mastitis. The next type of mastitis, as we know, is lactation mastitis, which I'll be speaking on. This is more common in breast feeding mothers or the lactating mothers. That's why it is known as puerperal mastitis. and as it can occur at any point of time during her journey of breastfeeding, but this condition is usually found in first 6 to 12 weeks of lactation and more common in the primary-parous ladies who are inexperienced. This condition is mostly found in them. And studies have shown that it can affect around 10 to 30% of the lactating mothers. They can suffer with a bout of mastitis during their entire course of lactation. Now we come to the causes of mastitis. As has been told elaborately, the basic cause of mastitis or the lactation mastitis is milk trapped in breast. Any condition which gives rise to clogging of milk in the breast tissue will lead to development of inflammation. We all know that during pregnancy, glands, the mammary glands and the ducts enlarge in size, they proliferate in order to prepare the breast for feeding after the delivery of the baby. So once the child starts sucking, more and more milk is secreted into the lactiferous duct, and at any point of time this mechanism is hampered either due to ineffective emptying of breast or inadequate production or poor latch or defective techniques. Anything which gives rise to hampering of this normal process will lead to stasis of milk, and stasis of milk leads further to proliferation and infection, leading to mastitis or the lactation mastitis. The bacteria are more commonly seen in the stasis of milk, and they proliferate there because milk is a very good medium for their growth. So milk trapped in the breast is the most common cause of lactation mastitis. Another can be blocked milk duct, because milk is flowing through these lactiferous ducts, and when the baby is sucking, the milk is the channel is free flowing, and any condition giving rise to blocked milk duct will further worsen the situation. The milk backs up in the ducts, and staphylococcus organism, which is more commonly seen or the most common organism infecting the breast, it proliferates there, leading to giving rise to inflammation and ultimately breast infection. Now, another cause of lactation mastitis is direct entry of bacteria into the breast tissue. It can occur both ways, either by baby's mouth, the bacteria enter the mother's breast, or directly the bacteria enter the mother's breast by skin surfaces. Can happen, generally seen in females having sore nipple, cracked nipple, or fissures in the nipple. The bacteria gain entry into the milk duct, and as we know that milk is a very good culture medium and breeding ground for the bacteria, they proliferate there and produce infection and inflammation. So the milk trapped, any condition giving rise to milk trapment in the breast or lactiferous duct causes lactation mastitis. Now we all know, and it has already been discussed in detail about all the risk factors. First is the improper latching technique. This is more commonly seen in primary-parous patients who are unaware about the feeding techniques, who don't have any family or emotional support to tell them. In fact, the healthcare providers also have not told her about the correct method of latching. So improper latching technique gives rise to lactation mastitis, because as you can see in the adjacent figure, the baby's mouth is only containing the nipple, and major part of the areola, or rather most of the areola, or almost all the areola is out. So this is the most common presentation which can be seen in a young inexperienced patient. Ideally, the proper latching should be a part of areola along with the entire nipple should enter the baby's mouth to have effective suckling and proper drainage of milk. So improper latching technique is the major contributing factor for development of lactation mastitis. Another important reason is sore or cracked nipple or any fissure in the nipple. What happens in these conditions? The mother herself is so reluctant to feed the baby because she's having excruciating pain. Whenever the baby's mouth touches the nipple, or whenever her own hand, by the movement of her own hand also, she feels a lot of pain. So she is reluctant to feed on that affected side of the breast. What she does is she feeds the baby through a other side, which is not having any cracked nipple or sore nipple. So the ultimate result is milk starts and goes on collecting in the affected side. It pents up, milk stasis occur, proliferation of bacteria occur, leading ultimately to infection and further worsening the condition. Then this third point is improper nursing technique. As has been demonstrated by Dr. Sneha Bhuya in previous slides about the various positions of nursing, whatever the mother feels, in whichever position the mother feels comfortable, that should be the proper position of feeding by that mother. Various positions like cradle hold, cross cradle hold, then Australian hold, football hold, all these positions are they are there, and whatever the mother feels, she should ideally nurse the baby with proper latch on techniques. Then inadequate emptying of breast, either because of babies having a tongue tie or a short frenulum, is not able to properly latch on the breast, or there are sore nipples, cracked nipples, or there is any the mother is inexperienced or reluctant to feed, because some mothers often have these phobia that their breasts will sag or they will lose their shape, so they don't they are less reluctant to feed the baby, and ultimately the result is that there is either no lactation at all, or even if she's lactating, she hardly lactates for few minutes. So inadequate emptying of the breast is another risk factor which gives rise to lactation mastitis. Then use of tight fitting braziers or tight fitting undergarments. What happens in these conditions when the mother is wearing too tight a brazier, that the milk ducts get clogged over a period of time, and ultimately they become blocked, leading to pent up secretion or the pent up of milk inside the ducts, which ultimately again harbors the bacteria and causes lactation mastitis. A previous episode of mastitis or a recurrent mastitis is another risk factor. And of course, poor nutrition of the mother, any slightest amount of infection will, proliferate and will give rise to all these signs and symptoms. Smoking again is a very big risk factor, because it produces a necrosis of the lactiferous ducts, leading to inflammation and infection of the breast tissue. Then, like with any other inflammation, all these signs and symptoms of mastitis can be seen in this women. The breasts can appear red, they are hot to touch, they are engorged or swollen, and often they experience excruciating pain or tenderness. Even with the slightest of movement of the hand, as I said, will produce a lot of pain, because milk is already there, their breasts are engorged, and it's not proper let down is not there, proper outlet of milk is not there, so they become very tender. Often mothers also experience burning sensation. They can have fever with chills, and fever can be as high as around 100 to 102 degrees, with all signs and symptoms of fatigue. She can have myalgia, malaise, and all flu-like feeling she can experience. Then diagnosis is as such quite simple, because it is based on anamnesis and physical examination. By anamnesis, I mean that proper history taking by the mother. She keeps on telling you how the event flows, right from right from after delivery, when the baby latches on, when she started breastfeeding, then the course of events follow. This is very helpful in making the diagnosis of lactation mastitis. And of course, we have to do physical examination and find out. Certain blood investigations are also needed, like complete blood count, etc. In rarest of the rare conditions, milk culture is also done. And if at all, with a proper due treatment, the condition is not improving even after 24 to 48 hours, then we ideally subject the patient to ultrasound or mammography or MRI, because this condition has to be differentiated. And she might be having an underlying abscess formation. In ultrasound imaging, we can pick up early deep-seated abscess, and with sonomammograms, we can pick up or we can differentiate this condition from inflammatory duct carcinoma, as has been reported, because this condition mimics, both the conditions have almost the same signs and symptoms, but they have to be differentiated, and there's absolutely no lump in either. So sometimes imaging techniques are also very, very helpful. Then we come to the treatment. First and foremost part of the treatment of lactation mastitis is supportive and only supportive treatment with effective milk removal, because the culprit we know, or the causative agent or the pathophysiology we know, is because of stagnation of milk in the lactiferous ducts. So effective milk removal has to be there. Either when the mother is feeding, she has to completely empty one breast, then switch on the baby to another breast. Not that she's breastfeeding and she feels that now the milk is less in this side, so I switch on the baby to other side. Here lies the importance of very effective counseling. So effective milk removal has to be there. And if she thinks that baby has breastfed totally, then what she should do, she should express that extra milk left inside the breast either manually or through the help of breast pumps, which are both manual or electronic, as Dr. Sneha has also mentioned. Then massage of the breast. This is very important. Massage of the breast helps in relieving the compression or the partial blockage of the duct. While the baby is breastfeeding, she should massage her breast in circular motion. Starting from top towards the nipple, she should massage the breast. And ideally nowadays, importance of lymphatic massage is also been highlighted, which is the massage of breast from the nipple towards the axilla, towards the lymph nodes. It also is seen to relieve the symptoms. Then even if these techniques fail, then hot compression also can be done, because in engorged breast, tense breast, the mother refuses to feed the baby, and whenever the baby latches on, she feels excruciating pain, so she refuses or she stops breastfeeding. So ideally we should advise her to have hot compression 5 to 7 minutes prior to lactation. A hot towel dipped in a hot water, squeezed properly, can be advised. We can advise to wrap this towel around her breast and gently massage the breast in order to relieve compression and inflammation. She can use hot water bottles or hot gel packs also for this. This should then, once she starts feeding, after the fed is over, after the breastfeeding is over, there lies the importance of cold compression. Ideally, it should be done 15 to 20 minutes after feeding. In cold compression, she can use ice water or ice cube pack or cold gel pack, and home therapy in the form of cabbage leaves. What do these cabbage leaves do? Cabbage contains, the leaf should be chilled, and it should be green, it should be fresh, and it should not be wilted. So what does this cabbage contains? I was very fascinated to see this cold compression by cabbage leaves. That's a whole, I've heard that's a age-old remedy for mastitis and engorged breast. What does it do? It contains, this cabbage contains a chemical known as glucosinolates. And under the enzymatic action, this glucosinolates is converted into isothiocyanates, which has an inflammatory effect, and it produces anti-inflammatory effect to the engorged breast, which is so painful. So this cabbage leaves also has a very important role to play. Then of course, rest, nutrition, and plenty of fluids also need not be mentioned. They have to be properly instituted. Mother's diet should be healthy with all the nutrients, calcium, milk, multivitamins, etc., along with proper platter. Then if at all after 12 to 24 hours the supportive therapy fails or the mother's condition does not improve, in fact it deteriorates, and lies the importance of pharmacological therapy. Analgesics are firstly given because they have both anti-inflammatory action as well as antipyretic action. The fever comes down, the inflammation is taken care of. Along with that, we have to add antibiotics because it is a bacterial infection, mastitis. If infective mastitis occurs, then we have to restrict the spread of infection deep-seated or to other adjacent loculi. Antibiotics most commonly used can be erythromycin, dicloxacillin, amoxicillin, or any generation of cephalosporins are equally good. And if the baby is having oral thrush or the mother is having fungal infection on the breast, then she can always have topical application and of antifungals and systemic. Of course, infection has to be treated, and the child's oral thrush has to be taken care of by application of gentian violet. So all these measures help, but we have to advise that even with the pharmacological treatment going on simultaneously, supportive treatment has a very important role and it should not be stopped. Mothers should be asked to continue the supportive measures also. The antibiotic coverage has to be given for around 2 weeks. Then if this mastitis is not taken care of properly, or in cases of neglected mastitis, the complication of breast abscess can occur. I won't go in detail. If the abscess is superficial, it has to be aspirated, or even the deep-seated abscesses are drained by multiple wide bore needle aspiration under local anesthesia. And if at all the abscess is large, it has to be drained surgically by giving incision and then breaking the loculi and septa and draining the abscess. Now, how to prevent this? Prevention is very, very important. As already told, we should encourage the female to breastfeed every 2 hours or more, because it should be a demand feeding and not the restrictive feeding. Every feed or every breast milk is tailor made, and every infant has its whim and fancies about breastfeeding. Some infants demand milk every 1.5 to 2 hours, while others sleep peacefully for 3 to 3.5 hours also. So it should be demand feeding, and ideally she should feed every 2 hours to keep the milk flowing through the ducts and to keep the ducts patent. Then if at all breast pump is needed, she is not able to breastfeed the child, then she has to pump out the extra milk, or if the mother is working, then breast pumps can be used. Then, as I said, massage the area using gentle circular motion, starting at the outside of the affected area and working towards the nipple. This helps in partial blockage, partial relief from the blockage of lactiferous ducts, because nipple baby's mouth acts as a very good breast pump. It sucks and clears off the partial blockage of nipple duct. So ideally, mother should be encouraged to breastfeed the child often. Poor latching techniques are also prevented by proper counseling, and she should be encouraged to feed on the affected side first. When the infant is hungry and sucks more strongly, thereby there's a strong chance that the blockage can be taken care of. And nipple has to be air dried after nursing in order to prevent cracking, soring, or development of fissures. Then warm and moist compression before feed is advisable, and cold compression 20 minutes ideally after feed is helpful. Plenty of fluids and rest should be given to the mother. And this last point is very important, that she should be advised to continue breastfeeding, because it's a myth that when mother is suffering and she's having infection or she's having fever, then people say that she's likely to pass on the infection to the baby. But ideally, this is not true. In fact, we have to burst out this myth and encourage breastfeeding, because whenever the mother falls ill, we have to tell that the mother is infected, not the breast milk. We have to tell that whenever the mother falls ill, ideally, a lot of antibodies, immunoglobulins, etc., are produced by her body in order to tackle that situation or counteract that infection. And these antibodies are passed on to the infant generously while breastfeeding. So she should be encouraged to breastfeed the child, even if she's having mastitis or even in breast abscess, she should be encouraged to breastfeed the child. So now to conclude my talk, lactation mastitis is an inflammatory breast condition, usually accompanied by infection, and requires immediate and appropriate treatment in order to avoid certain complications. The main principles of treatment are supportive counseling, as it has a very important role, and in fact, it is the main treatment, followed by effective milk removal, symptomatic relief, and an institution of antibiotic therapy. With timely, appropriate, and adequate treatment, recovery should be complete and normal function of the breast is restored with subsequent lactation. Thank you very much for the patient hearing.
Thank you, Dr. Charu, for your excellent and lucid presentation. You have indeed simplified the topic, and I would also like to thank organizers, Dr. Supriya and Dr. Vinita ma'am, for giving me this opportunity. Mastitis in breastfeeding patient, it is a very common problem and it is unavoidable. And you have rightly said it can be prevented by educating the patient about the positioning and proper latching to prevent the cracked nipple. And we can educate them about the complete emptying of the breast, so we can prevent the breast engorgement and the blocked duct. One thing I would like to just share with you all, sometimes non-puerperal mastitis is very common. I have found one woman at 45 years of age having recurrent mastitis, presented with recurrent mastitis, and I got blood sugar done, and she was found to be diabetic, and she responded not to antibiotic but oral anti-diabetic drug. So we should keep in mind, sometimes we get the patient for the first time in puerperium and we are not knowing about the diabetic status. So if there is recurrent mastitis, we can think of diabetes also. And of course, inflammatory cancer of the breast is also a known entity which can be confused with mastitis. So if there is persistent mastitis, in spite of treatment, we must rule out that. Thank you very much again.
Thank you, madam.
Thank you.
Yeah, it was wonderful presentation, Charu. You have explained well everything: diagnosis, treatment, prevention. I want to add only one thing, that if during antenatal visit, nipple should be washed and patient should be taught about the care, because many women have cracked nipple, inverted nipple, and if they take care during that time, then we can prevent many cases of mastitis. And
Yes,
continuous
very true.
drainage is also important. It should be done, and I think I had attended some webinar where it was taught that we should see the nipple also, and I used to do in my clinic. I used to do the patient, especially preemie, because they have not fed their babies, and many times their nipple remains inverted or cracked or even fissured or so. So we can get her treated, and even applying simple lotion, even body lotion or something else, can improve it. She can remove the crust which lies on the or gets stuck around the nipple. So we can prevent it. It was a wonderful presentation. Thank you all, especially Pratima Modi madam, Abha Rani madam, Vinita madam, and all the seniors who are there. I respect them, and my warm regards to all of them. Thank you, Supriya. You are very well.
Thank you, madam. In fact, even I would like to mention that, as rightly said by you, even we counsel our patients and we also advise care of breast to our all antenatal patients, whoever comes to our clinic, just to ensure that their nipples are well formed at the time of delivery and they are able to breastfeed properly. Thank you so much.
Thank you, Dr. Charu, for your excellent talk. And you covered all the aspects of mastitis during breastfeeding. And the key point is that the breast should be emptied regularly. That is, I think, that's the most important thing.
Yes, ma'am.
And now I thank all the chairpersons for running the session so smoothly. Thank you all. Now moving on to the third talk, we would like to call upon our first chairperson, Dr. Pratibha Singh. She is consultant laparoscopic gynecologist and IVF specialist at Bhagalpur. She is past state honorary general.
Anjana Di, we can't hear you.
Probably there's some problem with the net.
Anjana Di, are you there? some problem.
Hello.
Yes. Anjana Di, are you there? Is Nibhadi around? Nibhadi, can you just take this session?
We lost her connection.
Yeah.
So inviting Dr. Pratibha Singh as the chairperson. She's consultant laparoscopic gynecologist, IVF specialist, and director for Healing Touch Multidisciplinary Hospital at Bhagalpur. She's national coordinator of IAEC and diploma in advanced gyne laparoscopy also. And she's founder secretary of almost many societies, FOPSI and Bhagalpur Menopause Society, and past vice president of Bhagalpur Obsgyne Society, organizing secretaries of East Zone IMS conference and second AOGS BJ conference. And she has many active participation in many conferences.
Thank you, Doctor. Yeah. Well,
now my connection. Sorry, my connection was lost. Now I'm here.
Continue.
Our second chairperson is Dr. Supriya Jaiswal, who is present secretary of BOX, national communicator ISOPAB, and has won many awards. Very hardworking, caring for each and every member of our society. You are welcome, Dr. Supriya. And now I hand over the mic to chairpersons to continue the session with the talk of Dr. Basundhara Lal, and kindly introduce her.
Yeah.
Thank you.
Thank you, Dr. Anjana. Hello, can you hear me?
Yes,
Hello?
yes.
Yeah. So first of all, I'm really privileged to be the part of this webinar. And I just want to thank Patna and Bhagalpur Obsgyne Society, especially Dr. Vinita Singh ma'am, Dr. Rekha Jha ma'am, Dr. Supriya, Dr. Kavita Barnwal for giving me this opportunity. And we just heard a very stimulating talk by Dr. Sneha and Dr. Charu Modi just now. And now it gives me immense pleasure to introduce our next speaker, Dr. Basundhara Lal. She is from our own society. She's a consultant gynecologist working at self-employed Lal Hospital, Bhagalpur. She is the past secretary Bhagalpur OBGYN Society and past Health Week secretary IMA Bhagalpur in 2000 from 2015 to 16. She is at present, she is the secretary Bhagalpur IMA branch. So that is not written in her CV, but that is what she is now. And she is the recipient of Health Excellence Samman in 2018. And her field of interest is vaginal surgery and high-risk pregnancy. And today she is going to talk on failed lactation, how to proceed. Now, the commonest cause of failed lactation is mainly due to insufficient milk or due to no milk production, which usually occur due to waiting too long to breastfeed the child, which is very common in our part of the country, where there are certain traditions or certain rituals which they follow, that they will not feed their child just for one day, and after that, after finishing that ritual, they will start feeding their child. That may result into failed lactation sometime. There may also be supplementing the breastfeeding, top feeding will be there. Then maybe insufficient latching technique, which Dr. Sneha and Dr. Charu very nicely told, that is maybe the cause of failed lactation, and maybe also use of certain drugs, or if a patient has undergone certain surgery. So these may be the causes of some failed lactation. And today we have with us Dr. Basundhara Lal, who will be talking more on this. So over to you, Dr. Basundhara, for your presentation. Dr. Basundhara? You have to unmute yourself, Basundhara. Dr. Basundhara, please unmute yourself.
Press the red button.
Yeah, red button. Next side. On the left side, you see there's a yes. There now.
Again, you are muted.
Again, you are muted, Dr. Basundhara.
Yeah, I can find.
Yeah. Hello.
Yes,
yeah,
ma'am.
she's no problem.
Yes, start.
Problem in sharing, madam?
No, no, no. We can see your slides, but you have, yes. Yes. Yeah, now you start. Yeah, now we start. Now we start, yes.
Am I audible, madam?
Yes, yes.
My talk is on failed lactation, how to proceed. First of all, what is lactation? It is the process of secreting milk from breast, and it is a physiological process under neuroendocrine control. And what is failed lactation? Failed lactation is the condition where mother is not able to produce milk or weaning earlier than the mother desires. Now coming to the hormonal basis of milk synthesis and milk secretion. The principal lactogenic hormone is prolactin, which is secreted from anterior part of the pituitary gland and is critical for the establishment of lactation. Prolactin level decreases as lactation is established, but suckling stimulates prolactin secretion, which promotes continued milk production. Level of prolactin are directly correlated with the frequency and duration of suckling. The link between suckling at nipple and prolactin secretion involves a neuroendocrine reflex in which dopamine secretion is inhibited. Dopamine is prolactin release inhibitor factor. Milk letdown reflex is started by the tactile stimulation by the suckling newborn, which sets a neuroendocrine reflex and oxytocin released from the posterior pituitary gland. Oxytocin causes contraction of the myoepithelial cells of the breast, and milk is ejected through the duct into the mouth of the baby. Now coming to prolactin reflex. A baby suckles at the breast, sensory impulses from nipple to brain, prolactin secreted from the anterior part of the pituitary, prolactin goes to the blood to the breast and makes milk secreting cell produce milk. Oxytocin reflex, baby suckles at the breast, sensory impulse from the nipple to the brain, oxytocin secreted from posterior part of the pituitary, oxytocin makes the muscle cell around alveoli contract, and milk collected in alveoli flows along duct towards the nipple. What is the importance of oxytocin reflex? Oxytocin reflex is positively affected by mother's sensation and feeling like thinking lovingly about the baby, touching, smelling, or seeing the baby or hearing the baby cry. If mother is emotionally disturbed or experiencing pain or discomfort, oxytocin reflex doesn't work well and baby has problem getting milk. What are the causes of lactation failure? Causes either in the baby or in the mother. In baby, biological causes, and in the mother, psychological and social causes and biological causes both. Psychological and social causes accounts about 81%, and it is insufficient milk, unsuitable milk, refusal by baby, illness by the mother, maternal employment, advice by relative or friends, dislike for breastfeeding, fixed schedule feeding, lack of confidence, shyness, worry, stress, and religious customs. Breastfeeding related causes: delayed start, fixed schedule feeding, infrequent feeds, no night feeds, short feeds, poor attachment, bottle, and other fluids. Biological causes of the mother: local. Sore and cracked nipple 38%, inverted nipple 27%, involved breast 18%, mastitis and abscess 14%, others 3%, burn, scarring, breast injury, anatomically abnormal breast, leads to insufficient tissue, which is very rare, retained placenta, which is also very rare. Drugs causing suppression of lactation are calcitonin, diuretics, either loop or thiazides, dopamine receptor agonist, bromocriptine, and cabergoline, ergotamine, levodopa, contraceptives, pseudoephedrine, pyridoxine, and tamoxifen. Neonatal causes are neonatal illness, which leads to early maternal-infant separation and which interferes with initiation of lactation. Neonatal disorders associated with poor suck due to cleft lip and or palate, short frenulum, micrognathia, choanal atresia. Maternal or infant medications that causes drowsiness, neonatal asphyxia, preterm birth, Down syndrome, etc. and breast rejection. The complaint of insufficient milk is more often due to lack of knowledge about the normal behavior of a baby who usually nurses frequently and negative opinions of significant persons. The wrong perception by the mother leads to introduction of complementary feeding and negatively affects milk production. Now, when do you suspect failed lactation? These are the symptoms. When we suspect failed lactation, infant is not satisfied after feed, cries a lot, wants to nurse frequently, take very long feeds, improper weight gain, infrequent bowel movement, small in amount, dry and hard, less need to change diaper. What are the signs indicating failed lactation in first week? Weight loss greater than 10% of the birth weight, no regaining birth weight up to 2 weeks of life, no urinary output for 24 hours, absence of yellow stool in the first week, and clinical sign of dehydration. Now, how to proceed to failed lactation? Approach to mother. There should be a dynamic interaction between a breastfeeding mother and her infant over time. Most disorders of lactation are iatrogenic because of impeded establishment of lactation or inadequate ongoing stimulation and drainage of breast. Most breastfeeding difficulties are due to lack of knowledge, poor technical skills, and lack of support. Almost all problems are reversible. Prevention, early detection, and management should become a routine part of maternal and child health care. Antenatal screening for risk factors. These are breast examination, evaluation by systemic illness, maternal general condition and dietary habits, lactation assessment in third trimester, breastfeeding education, education regarding advantage of breastfeeding, education regarding disadvantage of top feeds, counseling by mothers to mothers with previous unsuccessful breastfeeding experience. It is very important that mothers should be accompanied by other influential members of the family, as attitude and knowledge of mother as well as her near ones should be changed in order to have successful breastfeeding. Natal and immediate postnatal, what to do? Medicated and interventional labor should be avoided as far as possible, which interferes with the instinctive rooting behavior to locate and latch onto the breast. Initiate breastfeeding as soon as possible after complete delivery of placenta, which leads to early breast stimulation and initiate early lactation. Breastfeeding on demand should be promoted. Regular breast drainage and stimulation promotes lactogenesis, initially hormonal based and later on orthocrine. Proper positioning, attachment, latching on should be supervised. Grooming in for 24 hours at the same bed. Separation impedes drainage and stimulation. Address local problem, biological causes immediately. Counseling regarding diet of mother. Instruction to be given to mother for successful establishment of lactation. Positioning, attachment, latch on. Frequency on demand, including night feeds. Duration varies between mother and infant pair. Pattern of breast use: first breast comfortably drained, followed by switching on to the second breast. Feed not to be terminated prematurely in sleeping infants. Mothers should be explained that it takes time for proper milk formation. Now, the management of biological causes of mother. Flat nipple and inverted nipple. Anatomical nipple forms only 1/3 of the teeth of the breast tissue in a baby's mouth. Reassurance may help and tell the mother that baby suckles from breast, not from nipple, and encourage her to give plenty of skin to skin contact. In case of inverted nipple, nipple doesn't protract. On attempt to pull out the nipple, it goes deeper into the breast. By the syringe method, it came out and baby can suckle effectively. In God breast, if baby is able to suck, mother should feed frequently. If pain and tightness doesn't allow suckle, then express milk and breast becomes comfortable, then breastfeed the baby. Cold compression can be done, paracetamol for pain and fever. It is already dealt by other speakers. Difference between the full and engorged breast. Full breast is hot, heavy, milk flowing, no fever. Engorged breast is painful, edematous, hard, tight, especially at nipple. Shiny, may look red. Milk not flowing, may be fever for 24 hours. Sore or cracked nipple, it is dealt by the previous speaker. Most common cause of sore nipple is poor attachment. Improving infant's attachment to the breast relieves the pain, and hind milk rich in fat should be applied. Systemic illness, endocrinopathies, and other chronic illness needs to be managed along with other measures for encouraging breastfeed. What is the planning in during hospital discharge? Infant weight less than 7%. If infant weight loss less than 7% plus good breastfeeding skills, then in that case, plan the discharge plus lactation assessment on follow-up. If infant weight loss less than 7% plus poor breastfeeding skills, then in that case, extended hospital stay. If infant weight loss more than 7%, breastfeeding assessment should be done plus extended hospital stay. Establishing relactation for those mothers with failed lactation on postnatal follow-up. What is the physiological basis of lactation on which relactation depends? It depends on the growth of the secretory alveoli in the glandular tissue of breast, secretion of milk, removal of milk. And it also depends upon the hormone, prolactin, development of secretory alveoli, secretion of milk, stimulus and nipple stimulation. Most effective stimulus are the suckling of an infant, daytime less than the nighttime suckling. Factors which affect successful relactation are infant-related and mother-related. Infant-related, willingness to suck, age of the baby, breastfeeding gap, feeding experience during the gap, intake of complementary food. Mother-related, women's motivation, lactation gap, condition of the breast, previous experience of the lactation, ability to interact responsively with her child, and support from family. If infant is willing to suck, encourage the woman. Put infant to breast frequently, 1 to 2 hourly, 8 to 10 times in 24 hours. Sleep with infant and breastfeed at night. Ensure good attachment. Let infant suckle at both breasts for as long as possible. Feed infant supplements separately using a cup. If infant is unwilling or unable to suck, in that case, ensure child is not sick. Skin to skin contact is proper. Offer breast anytime child is interested to suck. Otherwise, breastfeeding supplementer method should adopt. Breastfeeding supplementer method, in this case, use a fine nasogastric tube or other fine plastic tubing and a cup to hold the milk. If there is no very fine tube, use the best available. Cut a small hole in the side of the tube near the end of the part that goes into the infant's mouth. This is in addition to the hole at the end. This helps the flow of milk. Prepare a cup of milk, expressed milk or artificial milk, containing the amount of milk that her infant needs for one feed. Put on one end of the tube along her nipple so that her infant suckles the breast and the tube at the same time. Tape the tube in place on her breast. Put the other end of the tube into the cup of milk. Tie a knot in the tube. If it is wide, or put a paper clip on it or pinch it. This controls the flow of milk so that the infant doesn't finish the feed too fast. Control the flow of milk so that the infant suckles about 30 minutes at each feed if possible. Raising the cup makes the milk flow faster. Lowering the cup makes the milk flow more slowly. Let the infant suckle at any time that he is willing, not just when she is using the supplementer. Clean and sterilize the tube of the supplementer and the cup or bottle each time she uses them. Supplementing the infant. While mother's breast milk supply is become established, it is essential to ensure that the child receives adequate nutrition through bati and spoon. Breastfeeding supplementer. Supplement cow's milk diluted till 2 months of the age, 150 ml milk, 50 ml water and 5 grams sugar. To begin with, the supplement should be full 150 kilocalorie per kg per day, divided in at least 8 feeds. As breast milk increases, supplement should be reduced. Child's weight should be regularly monitored. How to reduce supplement? In some cases, child shows less interest by the refusing supplement, refuse to suck on second breast, reduce total amount of supplement in 24 hours by 50 ml, continue reduced feed for next few days. If by behavior and weight gain, 125 gram per week feed appears to be sufficient, reduce it further, else continue the same for 1 more week. Galactogogues can be used to increase the milk production. These are metoclopramide, domperidone, it is dopamine antagonist, and sulfide or chlorpromazine. Some natural galactogogues are shatavari, fenugreek, anise, basil, fennel seeds, garlic, ginger, jaggery, coconut, bajra, khaskhas, pepper, panjir, sonat, salt, jivanti, and panjiri. But best galactogogues are baby suckling at the breast in correct position. To conclude, supportive breastfeeding policies in hospital constitute the foundation for initiation of successful breastfeeding by mothers. Constant reinforcement and support to all lactating mothers is essential to maintain lactation. Self-confidence, support of family members, and regular follow-up. Thank you. Hope I am on time.
So, wonderful talk by you, Dr. Basundara. So on failed lactation, how to proceed, it was very extensive, and you have touched upon all the parts of this, like hormonal basis of milk synthesis and milk secretion, prolactin reflex, then establishing relactation. That was very nice. And we should support initiation of breast milk at all stages, in all cases, whatever we need to do to motivate the mothers to breastfeed their child. That is the best food and a complete food for the child, as we all know. Your talk was wonderful, and thank you very much for your presentation.
Thank you, thank you, Dr. Basundara. It was a wonderful talk, and you have covered everything. And galactogogues, which you have told, it was very good. Plus, what you have told, that suckling is the most important. That is very important, and patients should be told or should be taught that how they should latch their baby to the breast. That is very, very important. So, and that should be counseled, because many a times patients, they don't understand. I mean, they are not so well versed with that. So they should be taught how to hold their baby and how to feed their baby. So thank you so much for such wonderful talk. Thank you so much. And thank you everybody for giving me this opportunity. Thank you.
Over to Anjana Di.
Thank you, Dr. Basundara Lal, for your talk. And your talk was really extensive and very nice. And I think everybody must have been benefited by your talk, because this failed lactation is a very tough thing. I have faced this situation in my daughter's delivery. First delivery, it was, I think it was very nice and she lactated very well. But in the second time, it failed and it could not be revived. She only fed for 2 months. She was only able to feed for 2 months. And after that, it was just a complete failure and no drugs worked. So, but as you said, the suckling is best galactose, I do believe. But here it was a failure. But doesn't matter. Your talk was very nice. And thank you, chairpersons. You did a very nice job in conducting this session. And now I invite Dr. Rekha Jha and Dr. Leena Nair to chair the last session. And the speaker is Dr. Arjun Agarwal. Dr. Rekha Jha is president of BOGS Bhagalpur and has been already introduced by me. She has keen interest in academics and hope she will take her society forward. Dr. Rekha, you are welcome. And our second chairperson is Dr. Leena Nair Lal. She is a consultant obstetrician and gynecologist at Lal Clinic, Bhagalpur. Past president at Bhagalpur Society, past treasurer Bhagalpur Menopausal Society, and Sabse Bihar, Jharkhand. Now, and I hand over the mic to the chairpersons to introduce the speaker, Dr. Arjun Agarwal. Over to you, chairpersons.
Before that, we will welcome Dr. Arjun Agarwal to our platform.
Thank you, Dr. Anjana Sinha and Dr. Supriya Jaiswal. Dr. Arjun Agrawal is MS MCH, Associate Professor Surgical Oncology, Rohilkhand Medical College and Hospital, Bareilly. He is MBBS and MS JNMC AMU, MCH from Vaidehi, Bangalore. He has operated more than 1,000 major oncology cases in the last 3 years. He has fellowship in breast oncology from AIMS, only surgeon in West UP to use ICG dye to evaluate sentinel node in breast, endometrial and stomach cancers. He started fellowship in oral oncology in 2020. He has more than 50 international and national publications. So, Dr. Arjun, I once again, on behalf of Patna Obs Gynae Society and Bhagalpur Obs Gynae Society, invite you and welcome you to give your speech.
Thank you, ma'am, for inviting me. It is really a pleasure to be coming on your forum to present my thoughts on this topic. I am sharing my screen. Can you all see my screen?
Yes.
Yes, we can see.
And am I audible?
Yes.
Yes.
Yeah. So the topic which is given to me is inflammatory breast cancer. Before I start with my core topic, since the theme of this webinar is breastfeeding, I would like just to say a few words regarding breastfeeding and cancer. So breastfeeding is helpful both for mother as well as child in terms of prevention of cancer. Mother, everybody knows that if a mother breastfeeds her child for more than 6 months, preferably more than 12 months, then the chances of her having breast cancer are less. Actually, there is a study which is done by the Eastern College of Europe, in which they say that if a female breastfeeds her child for more than 12 months, then the chances of her having breast cancer reduced by 4.5%. One more study was done in Australia. The females who breastfeed their child for more than 31 months. This is a cumulative time for one child, two child, or three child, a cumulative time of more than 31 months versus those female who breastfeed their child for less than 12 months. What they found that there was a decrease in the incidence of breast cancer by 93%. So definitely breastfeeding is good for mothers in terms of prevention of breast cancer. As far as the child is concerned, there is no direct relation that a child who is breastfed, he has less incidence of malignancy. But definitely, if a child is breastfed, then the chances of obesity are less, number one. Number two, the immunity of the child is good. And we all know that decrease in immunity and obesity are directly linked to many cancers. So breastfeeding also prevents cancer in children indirectly. Now, I will divide my seminar into few parts. First is history about inflammatory breast cancer. Then what is the actual burden of disease? Then I will go to the clinical presentation, which is the most important part of inflammatory breast cancer. Then I will tell you how to diagnose it, how to stage it, what is the standard treatment for inflammatory breast cancer, and finally, what is the prognosis. So, starting with the historical perspective of inflammatory breast cancer, the historical identification of of inflammatory breast cancer is very important, is acceptance of classical clinical criteria that differentiate it from other forms of locally advanced breast cancer. So, like I was listening to the seminar and I heard many of you speaking that how mastitis masquerades as inflammatory breast cancer, and how we find it difficult for anybody, for a clinician to diagnose inflammatory breast cancer. So that is why it was very important to know that how you should differentiate between a breast cancer, a locally advanced breast cancer, and inflammatory breast cancer. So Lee and Tenenbaum in 1924 first time gave this disease an inflammatory breast cancer a name, and they told that yes, it is categorically and prognostically different from a routine invasive breast cancer. As far as the incidence is concerned, inflammatory breast cancer corresponds to around 1 to 5% of all invasive breast cancers. Means the incidence is very rare. It's not a common cancer. We should all know about this. And it usually presents a decade younger. Usually the normal age for a breast cancer presentation is 50 to 60 years, but inflammatory breast cancer usually present in fifth decade, which is 40 to 50 years, and it carries a bad prognosis. Bad prognosis because usually it's a triple negative breast cancer in which estrogen and progesterone receptors are absent, and it is usually a HER2 positive cancer. Now, coming on to the clinical features, like I told, this is the most important part. There are few points everyone should know that how we should diagnose a case of inflammatory breast cancer. The diagnosis of inflammatory breast cancer is clinical. It's not radiological, it's not histopathological, the diagnosis is clinical. The salient points are, number one, the onset is very recent. Usually in a routine breast cancer, patients say that they have a breast lump for more than 6 months. But in cases of inflammatory breast cancer, the onset of lump is less than 6 months. And in many cases, we find it to be less than 3 months. So any lump with a recent onset history. Second, a lump or no lump with a erythema, which is more than 1/3. That is, the skin on the breast, if more than 1/3 of the skin of the breast is having redness, it is having erythema, it is indicative of inflammatory breast cancer. Number 3 is a purely orange appearance. And number 4, a lump which is usually absent can be present. So any female who is having recent onset of a lesion, probably which is a erythema, which is more than 1/3 of the breast, which is having a purely orange appearance, it may be having a lump or it may not be having a lump. This fits into the clinical criteria of inflammatory breast cancer. And when you do a biopsy in such patient, if you find a dermal lymphatic invasion in the lymphatics, when there are tumor emboli in the lymphatics of the skin, then this is a pathognomic feature of inflammatory breast cancer. It is important to know that dermal lymphatic invasion is a pathognomic feature, but it is not a diagnostic feature. Diagnosis is clinical, but dermal lymphatic invasion is a pathological prognostic feature of inflammatory breast cancer. Other features which can also be present in inflammatory breast cancer are, number 1, pain, number 2, thickening of skin, then a dimpled skin, then breast enlargement or engorgement, or presence of axillary nodes. So these features can also be present apart from the classical features of inflammatory breast cancer. Like these, you can see in these images. In this image number 1, you can see that there is erythema on the breast skin, which is involving more than 1/3 of the breast. Same features are seen in picture 2 and picture 3. There is no visible lump, there is no discharge, except for the picture 1. Nipple is almost normal in both these females, but all these females had inflammatory breast cancer. Then, like as I told, It can present with pain in the breast, or it can present with axillary lymph nodes, or some itching or some swelling in the axillary tail also. So these are common and some uncommon features of inflammatory breast cancer. So what do we do when we have a patient of when we suspect a patient of inflammatory breast cancer? Like in all breast cancers, before putting a needle, before doing an FNEC or before doing a biopsy, the first step is always radiology. Because what is our histological procedure depends upon what is the radiology. We have a scoring system which is known as BIRAD scoring system, BIRADS, which stands for Breast Imaging Radiology Assessment and Data Analysis, which tells us that how extent is the BIRAD score. Usually when the BIRAD score is 3 or more, it is suggestive of malignancy, and in those cases we go for a core biopsy. So the investigations, the treatment is everything is same, like in cases of a routine invasive breast cancer, for an inflammatory breast cancer also. But there are some peculiar features in inflammatory breast cancer which are different from routine invasive breast cancer. As you can see in this image is a mammograph of a patient who was having inflammatory breast cancer. There was no lump in this patient, but there are areas of microcalcifications, and most of the changes are seen in the skin, in the nipple, and in the subcutaneous area. In this image also, we can see that the whole skin is inflamed. You can see that there is subcutaneous collection in all these patients. So more than a lump, there are more changes in the skin. I heard that you were talking about core biopsies. Yes, to diagnose breast cancer, we never do an FNAC. We always go for a core biopsy. There are different Frenches of core biopsy gun. We usually use this 12 gun, which is of a violet color, in which some local anesthetic is given on the skin, and this gun is used to take 3 or 4 core biopsy samples from the patient and is sent for histopathology. If we have clinical features which are suggestive of inflammatory breast cancer, and on a core biopsy, if we see tumor embolus in the dermal lymphatics, then we can make a diagnosis of inflammatory breast cancer. So you can see in this image, we can see that there are tumor emboli in dermal lymphatics. And like I told you, the presence of dermal lymphatic invasion is not needed to diagnose an IBC, but it's a pathognomic histological feature. So this is why IB, inflammatory breast cancer, is important, because it has a bad prognosis. Although it is a form of locally advanced breast cancer, but if we compare the Kaplan-Meier graph between a locally advanced breast cancer and inflammatory breast cancer, as you can see in this image, the locally advanced patients are having a median life of 6.4 years, but patients of inflammatory breast cancer, it's usually 2.9. As far as the TNM classification is concerned, inflammatory breast cancer, whatever be the size or whatever be the extent, it is directly classified as a T4D lesion, which is the highest T stage possible. So that shows that how the AJCC has taken this inflammatory breast cancer to be the most important part. Whatever be the size of the lesion, but if we are having an inflammatory breast cancer, it directly goes to the T4D level, which becomes a locally advanced breast cancer, and it is classified to have a minimum stage of 3A, even if it is N0. So once we have made the diagnosis clinically and histologically, next question is how to stage the patient. For a locally advanced breast cancer, the standard staging protocols are a CECT of thorax, a CECT of abdomen, and a bone scan. But since the chances of metastasis in inflammatory breast cancer are 10 times more than a locally advanced breast cancer, therefore, if we have a facility of PET scan, then the imaging of choice for staging for inflammatory breast cancer is PET scan. If you don't have the facility of PET scan, then the minimum investigations you need is a CT thorax, CT brain, CT abdomen. These are the minimum investigations that are needed. Now, coming on to the treatment of inflammatory breast cancer, the treatment is exactly the same as a locally advanced breast cancer. Like we all know, the treatment options for breast cancer are for the local care, we do surgery and radiotherapy. And for systemic treatment, we go for hormonal treatment, chemotherapy, and immunotherapy or a targeted therapy. Same are the different approaches that we use for inflammatory breast cancer. Trimodality therapy is the treatment of choice for all breast cancer. Same goes for inflammatory breast cancer, in which first step is to give neoadjuvant primary systemic chemotherapy. We never operate cases of inflammatory breast cancer first. First, we have to give systemic primary therapy. After that, we do a mastectomy and axial lymph node dissection. Then we give radiation to chest wall as well as regional lymph node. And then finally, we give adjuvant endocrine treatment depending upon the hormonal status of patient. I am seeing my screen. Do I have to finish in 1 minute? Okay, I'll continue. So there are different chemotherapy regimens in inflammatory breast cancer, like in all locally advanced breast cancer. There are many studies which were. Sorry, I have electricity failure. I'll continue with my presentation. There are different types of studies which were done as far as to decide the chemotherapy for inflammatory breast cancer. One study was done in Italy for 68 patients, one by UPenn in 52 patients. But the study which was done in British Columbia, which involved 308 patients of inflammatory breast cancer, this showed that the intensive chemotherapy, which we also call as a dose-dense chemotherapy, was found in having a pathological complete response rate, which happened to be at the rate of 33%. So this is the most important thing in inflammatory breast cancer, is that if after neoadjuvant chemotherapy, we achieve a pathological complete response, then it is a very good prognostic feature. So HER2 therapy is also used if the patient is HER2 positive. As we all know that trastuzumab is the treatment of choice for HER2 positive patients. This Herceptin, this binds to the HER2 receptors, and it causes decreased signaling of Herceptin. Then after we do a neoadjuvant chemotherapy, next step is to operate the patient. Question is, what surgery should be done? Whether modified radical mastectomy is compulsory on all patients, or we can have lumpectomy offered to few patients as well. So breast conservation treatment is not feasible for cases of inflammatory breast cancer, and a standard modified radical mastectomy has to be given. There is no concept of breast conservation therapy. Modified radical mastectomy, in which breast, along with this whole gland, the tumor, as well as at least level 1 and level 2 axillary lymph nodes are removed. Since the cases of inflammatory breast cancer are quite less, so there was a very small study of 13 patients of IBC, and in which treatment was done, preoperative chemotherapy, and breast conservation was tried in those patients. But at the end of the study, they found that 7 of 13 patients, mean more than half of the patient, they developed local recurrences. Therefore, they concluded that breast conservation should never be tried in patients of inflammatory breast cancer. So after the first step was surgery, then came, the first step was neoadjuvant chemotherapy, next was surgery, and after that surgery, we give external beam radiotherapy to these patients with a dose of 50 grays, which is divided into 25 fractions. And depending upon the hormonal status, if the patient is estrogen positive, we give tamoxifen for premenopausal females for 10 years. And if the female is postmenopausal, we offer either letrozole or anastrozole. Follow-up protocol after treatment is same for all breast cancers, which is history and physical examination every 3 monthly for first 2 years, followed by 6 monthly for the next 3 years, and then annually. Patients should always have annual mammography done. So the take-home message is that inflammatory breast cancer is different, and often there is no lump present. But should note that the diagnosis is clinical diagnosis in which any onset of symptoms which is less than 6 months, with a skin erythema which is more than 1 year, and with pudgy orange appearance, this is usually the diagnostic feature of inflammatory breast cancer. It is important to know inflammatory breast cancer because its prognosis is worse than a routine locally breast cancer. I thank you, the Patna Obs and Gynae Society, for inviting me to this wonderful seminar. And definitely, I heard all the other speakers talking wonderful lectures about breastfeeding, and it was really informative. And I really thank you again for inviting me to this wonderful presentation.
Thank you, Dr. Arjun. That was an excellent talk, and you covered almost all aspects of this inflammatory breast cancer. It is very important to know about this disease because though it is rare, but it is very aggressive and progresses very fast. I would like to ask you a question is, how long do you give the neoadjuvant therapy before surgery?
Neoadjuvant
How long?
chemotherapy.
Because since it's very aggressive, how long do you wait for it?
The standard chemotherapy regimen in breast cancer is for 8 cycles, in which first 4 cycles are given of adriamycin and cyclophosphamide, which is 3 weekly.
Okay. We can't hear you, Dr. Arjun.
8 cycles of neoadjuvant chemotherapy, and after the 8th cycle of paclitaxel, we wait for 3 weeks, and after then we operate the patient. If the patient is HER2 positive, then along with preoperative chemotherapy, we also start trastuzumab. Am I audible?
Yes, yes.
I mean, your audio is breaking in between. So thank you, Dr.
Can you hear me now?
Excellent talk. And it is really important to know because it is confused with mastitis, and it is so fastly progressive that we must learn about this inflammatory breast cancer and try to detect it as soon as it is possible because it does not give us much time. So thank you very much for all the information that you've given to us, and we hope that we'll be able to detect the patients in time and provide, or refer them timely so that proper treatment can be initiated in time and better prognosis can be advised for the patients. So thank you very much for the talk, and I thank the Patna Obs and Gynae Society and Bhagalpur Obs and Gynae Society for giving me the opportunity to chair this session. Thank you so much.
Over to Anjana Di.
Yeah, thank you, Dr. Arjun Agarwal, for your beautiful presentation, and you made us know all about this inflammatory breast cancer, and hope all have been benefited by your talk. Thank you, chairpersons. You were amazing in your job. Now, the time has come to say goodbye. For this, I would like to invite Dr. Nibha Mohan to thank you all. She is Joint Secretary POGS and served the society in many capacities. And she is Secretary of IMS Patna and has presented many papers in national and international conferences. Over to you, Dr. Nibha.
Thank you, Anjana Di. Thanks for calling me. It's a great moment for me to propose vote of thanks for such an important webinar, celebration of World Breastfeeding Week. Indeed, at this platform, we all are aware about exclusive breastfeeding. But then by organizing this webinar on this topic and listening to all such good speakers, I think all of us, all who have joined in this webinar must have imbibed some important tips so that we can help our feeding mother for their exclusive breastfeeding. So at the outset, I wish to thank President POGS, Dr. Vinita Singh, and Secretary Dr. Supriya Jaswal, and President Bhagalpur Ops Gynae Society, Dr. Rekha Jha, and Secretary Dr. Kavita Barnwal, who jointly organized this important webinar. Now I must thank from my core of heart to all the speakers. Dr. Sneha Bhuyar, Chairperson Breast Committee Foxy. She talked so beautifully and a very useful topic like practical guide, everything about breastfeeding. In fact, she talked about everything about breast problem. And I think at least I learned that prolactin secretion is better and more at night. So feeding in night is more, it's a better. And also that lying down position is also good. It's not bad. So like small tips, I think you all must have learned, and it's so helpful. Then I thank our own Dr. Charu Modi, who talked so beautifully on mastitis following breastfeeding, such a common problem. And she explained what to do when we face such common problem. Thank you, Charu, for explaining all lots of this common problem. Then I must thank Dr. Vasundhara Lal from Bhagalpur. And she also explained beautifully about failed lactation and how to proceed. And such a common problem and such a frustrating problem for a patient and doctor. And she explained everything of it. Thank you, Dr. Vasundhara. Then I must thank Dr. Arjun Agrawal, onco-surgeon from Bareilly, a fantastic surgeon, I must say. And he explained so beautifully about inflammatory breast cancer. So we must know how to pick up this deadly condition at the earliest possible. And you explained it so beautifully. Thank you, sir, once again. Then I must thank all the chairpersons who spared their valuable time on this working evening. My special thanks goes to the senior most, I think, Dr. Preeti Bala Sahai from Ranchi. Thank you, Preeti Di, for sparing your time. Then Dr. Vinita Singh, our own president, Dr. Poonam Lal, Dr. Kavita Barnwal, Secretary BOGS, Pratibha Singh, National Coordinator IAC Foxy, Dr. Supriya Jaswal, and Bhagalpur of Gynae Society President Dr. Rekha Jha, and Treasurer Dr. Leena Nair. Thank you all. You all did a fantastic job in chairing all the sessions, and you gave such important inputs also. Then my sincere thanks to all the senior members for their gracious presence. I must thank Madam Pramila Modi, Madam, who joined right from the beginning and continued throughout the session. Pranam, Madam, and thank you all. Thanks a lot. And my thanks also goes to all other senior members who I can see, Dr. Abharani Sinha, Dr. Neelam, Dr. Rita Sinha, Dr. Prakriti Gupta, and everyone. Then our thank goes to all the office bearers of our society, Vice President Dr. Pragya Mishra Chaudhary, Clinical Secretary Dr. Anjana Sinha, who also convened the whole session so beautifully. Thank you, Anjana Di. And Treasurer Dr. K. Manju, our executive committee members, Dr. Rita Jha, Dr. Ranu, Dr. Amita, Dr. Meena Samant, and Dr. Rupam Chandra. Thank you, everyone. And my last but not the least, all the delegates, all the members of both the societies who joined this webinar and made this webinar so successful. At the end, I must thank our pharma partner for their cordial help. So thank you everyone. Thanks once again.
Nibhadi, we would thank Anita Enterprises, who has done this program this time.
Okay.
Anita Enterprises.
I think for the first time he has done for us, and I think he'll continue for this, and we'll take help from him most of the time. And he has done beautifully. I can.
Yeah, he has done beautiful. Yes.
Yes, very seamless.
Mr. Rakesh and Hari.
First time he
the
has
whole
done and
team.
so beautiful.
Their new beginning of this era.
Yeah.
Thank you very much, ma'am.
Thank you.
Okay, thank you everyone. Good night.
Bye.
Thank you.
Thank you.
Thank you all so much.
Congratulations to all the organizers. It's a very good
Congratulations.
webinar.
Thank you. Thank you, Leena.
Rekha madam, congratulations.
Seriously, Supriya. Supriya has done taken great fun. She has done everything. I just asked her to, we will do jointly, and then she took all the pain. And for really nice presentation. Nice.
Nice to be joining sometimes also. Sometimes
Thank you, Pratibha Di. It's all teamwork, both secretary presidents and all of us. We all do together, and then it becomes a great success.
Really.
Thank you very much, all of you.
Okay.
Vinita
Okay, thank you. Good night.
विनीता दी अभी लग रहा है she is busy. Actually working day है ना, तो that is why she will
Yes.
be.
So special thanks to all the speakers, all the chairpersons, everyone.
We have got Poonam Lal, Dr. Poonam Lal. She is the chairperson of POGS breast committee in this tenure. Yeah.
Yes.
And Neelam Di, I can see you.
Bogs and bogs. Earlier also we were bogs.
लेकिन बहुत अच्छा था. Notice Charu and Sneha's talk. लेकिन आज एकदम एक्चुअली दिमाग से उतर गया था. Really speaking. अभी याद आया.
मेरा मिस कॉल देख के याद आ गया नीलम दी को.
हाँ, मिस कॉल देख के याद आया तो वो भी बहुत लेट. But still जितना देख सुने बहुत अच्छा था. Inflammatory breast disease के बारे में. That was good. Very good.
All the talks were very good.
हाँ, must be.
Yes.
चलो थोड़ा सा बॉक्स के लिए कुछ किया है भेजते हैं.
चलो विनीता दी आ गई.
चलो विनीता.
Thank you विनीता दी.
विनीता दी अनम्यूट करिए. अनम्यूट.
हाँ हम अनम्यूटेड है भाई. सुनाई नहीं पड़ा.
विनीता दी अनम्यूट. विनीता दी you are muted. Vinita Di, you are muted.
Oh, sorry. It's so difficult to unmute and mute. So it was a Neelam Di. चलिए बहुत अच्छा लगा कि नीलम जी ज्वाइन की हैं. So really we had a wonderful seminar and it was very very nice, very well organized. And Rekha Di, it was really wonderful. आप लोग के साथ भागलपुर सोसाइटी के साथ हम लोग का हमेशा हो रहा है. And Leena is there, such a wonderful, beautiful lady. Leena is there, Kavita is there. So it was.
Thank you so much, Vinita Di.
It was very nice,
I would like to
collaborate in future also. We should collaborate in future.
Vinita.
Sure, we will be having, yes.
Very nice. बहुत बढ़िया.
Yes,
मैं कुछ कहना चाह रही हूँ.
हाँ बोलिए.
शुरू से हम लोग के साथ हमारे सीनियर मेंबर्स डॉक्टर शैल बाला श्रीवास्तव, डॉक्टर किरण सिंह, ये लोग सारे जुड़े हुए थे. And I wanted to thank them also.
Thank you.
Dr. Indu Singh, Dr. Anita Kumari, all senior members, they were with us for 2 hours. So I wanted to thank them also.
Thanks from our side also. Thank you very much, madam.
बहुत बढ़िया रहा मैडम.
Yes. So thank you very much to all participants.
Hi, madam. Hello.
Thank you, Vinita.
Thank you very much. Thank you to all
very
of you,
good
all
presentation, Dr.
participants.
Charu and Dr. Vasundhara.
Yes,
thank you so much.
It was very nice presentation. So let us say goodbye to everyone.
And good night.
And we will meet again in next webinar.
Yes, sure, ma'am.
Okay.
So
bye to everyone.
Thank you. Bye. And good night.
Good night.
The host can end the meeting. So bye. Good night, everyone. We'll log out.